Hello everyone, good morning. We are from Team Scientech. So imagine waking up in a world where you cannot speak or hear. You try to order food, ask for direction, but nobody can understand you. This is the story of 430 million people worldwide who cannot speak or hear. The number is projected to reach 700 million by 2050. In underserved regions like South Asia, there are 131 million people who are facing speech and hearing impairments, and most of them do not have access to assistive technology. Meanwhile, in developed regions like US and Europe, there are 26 million people who are facing similar challenges. Some solutions exist, but they are very expensive. They lack portability, customization, and some camera-based solutions raise privacy concerns. For example, the Brightsen gloves offer glove-based translator, but it's very expensive. It lacks some essential features like voice-to-text conversion, gesture customization, emergency alerts, while Tobii Dynavox is even more pricey, and it is not suitable for sign language users. It's very bulky, so it lacks portability. The camera-based solutions often fail in low light condition and raise privacy concerns in public places. So according to feedback from around 300 online survey, our research found that the current solutions are very expensive, they lack portability, customization, and they raise privacy concerns, while our user need seamless two-way communication, privacy, customization, multi-language support, and most importantly, affordability.
To tackle these user needs, we are introducing our project, SignTalk Glove. SignTalk is a smart assistive glove that translates sign language into text and voice in real time while also being portable and affordable. Now, here are some of our key features. We are translating gesture into voice and text while also having multi-language support with mobile app integration for emergency alerts, customization, cloud-based updates, and other facilities. Now, question is, how does it work? So we are using haptic sensors such as inertial sensors to take the data from the user and send it over to a processing layer. Our processing layer uses embedded machine learning models and DSP techniques to classify each of the gestures back into alphabets and words, and we can use text-to-speech to convert them into voice. Now, what sets us apart? As you can see, our solution is about 10 times more affordable compared to the cheaper solution in the market, while also having certain features that make us better than the rest. And most importantly, our solution is customizable and scalable because of AI-driven updates. Here's a visualization of our prototype, and we have significantly improved that using further iteration and experimentation. So what are our success stories? We fine-tuned our model with multiple different sensors, and we experimented. So we have made the lowest, the most affordable solution thus far. We have successfully translated Bengali Sign Language, and now we're working with American Sign Language, and we have successfully integrated text-to-speech. Now, every success story has its limitations. And some of the limitations that we face is the limited gesture data. And we aim to mitigate that using crowdsourcing. Finally, embedded machine learning has certain trade-offs because of shallower models, and we want to mitigate that using few-shot machine learning calibration. And finally, in the future, we want to integrate flexible PCBs to mitigate the hardware bulkiness issue. So, what else is in store? We are currently using time series deep neural networks, but we are hoping to look forward to LSTMs and bi-LSTMs for advanced machine learning. And we are also hoping to incorporate brain-computer interfaces for paralysis patients. Here's the team. These are our respected advisors. These are just some of the achievements. And now, what's the impact? We believe SignTalk Glove will give voice to millions while also being affordable, portable, customizable, and scalable, and address some of the SDG goals as shown here. Now, we believe in a world where everybody can communicate whether they can speak or not. And with SignTalk, this world is possible. Thank you.
Did you have to start with your own glove? Like, is there no glove that you could have used that would have captured the same gestures? That's my first question. And then I liked the architecture that you presented, but the software architecture that you presented. But I wonder if, if you're a university team whose semester is ending, if anyone is really going to be able to use that in the future, and if it's going to be published in some way that would allow people to slot into different parts of that, given that this is a very ambitious project.
Thank you for the question. So, one of the issues that we faced is, there is no existing glove that we can use to collect the data. So that was the first gap that we wanted to mitigate. There are solutions, for example, flex sensor solutions out there. I mean, UCLA had a flex sensor solution with one single inertial sensor. So, but we think that our one is better because we are using 5 inertial sensors for each finger. So that enables us much more precise gesture recognition. And we are using Edge Impulse. So Edge Impulse is an open framework for embedded machine learning. And we can, collect data using crowdsourcing. So that's the amazing part about this. So our lacking with data can be mitigated.
You said it was like an IoT device. Does that mean it requires like really high quality data to use at all times?
Not really. The reason why we said it's IoT is because we are using an ESP, right? So ESP is readily available, and you can connect to the Wi-Fi, and we are sending the translated gestures into our Firebase server, and our Firebase server is then our mobile app is fetching the information from the Firebase server.
Do you guys have like a battery to your device, and like how long can it run?
So that's the best part about embedded machine learning, because we're using microcontrollers and not microprocessors. So embedded machine learning means we are using very constrained resources, mostly memory and performance. And TinyML, what we're using, is extremely performance efficient. So we believe that with even a 750 mAh battery, it can last for a day.
I have 2 questions. One, how do you envision the communication between the user? Because your display, I think your prototype is a display rather than voice outputs.
No, we can have voice outputs, so text-to-speech is available.
So your vision is that the user will sign, and it would be voice output to the counterpart, the audience. And that's working already in the prototype. Yeah. Okay, great. Now, my second question has to do with the prior judge asking you. Great, challenging problem. You're adopting cutting-edge technology to solve the problem. How do you see this going beyond a pilot for competition as a student, projects?
Yeah, actually, we started this as a business project. So our research gave us the confidence that we can take it much further. So we are confident that in the future we can do some supply chain fine tuning and reduce the cost even more. We're aiming to first target developed markets and then subsidize for the underdeveloped markets.
Hello everyone, my name is Daniel. I'm the founder and inventor of Biliroo. Meet Yusuf. He's born a healthy baby in sub-Saharan Africa, but after a few days his parents notice that his skin and eyes are turning yellow. He has severe jaundice. It's a common problem. 1 in 10 infants worldwide develop moderate to severe jaundice with high levels of bilirubin in their blood. Unfortunately though, their local hospital doesn't have the equipment to treat the jaundice. So he's transferred to a larger city where he undergoes an exchange transfusion as a last resort. It's too late though. Severe jaundice has already led to permanent brain damage. Yusuf isn't alone. 6 million infants with moderate to severe jaundice lack access to this critical treatment of phototherapy. In the US, treatment is relatively straightforward. Neonates are routinely treated with phototherapy, where the blue light on top converts the bilirubin into a form that can be excreted, and babies can live healthy and happy lives. Unfortunately, due to the high cost of the machines and a lack of continuous electricity and spare parts, there are 6 million infants without access, like I mentioned before. Personally, I was born and grew up in the country of Nepal, and the nearby hospital had limited access to phototherapy because of sporadic electricity. What can we do for these infants? Well, using a filter, we could harness the sun's light, blocking the harmful UV radiation while allowing for therapeutic blue light to pass through to treat the jaundice. These simple, low-cost, non-electric filters have been clinically proven in research to be as effective as conventional phototherapy. Currently, though, there isn't a mode of delivery that has been developed, and there's nothing yet on the market utilizing them. To have an effective treatment in a limited resource setting with marginalized populations, it'd be ideal to involve the parents more to ensure that babies don't overheat and that nurses aren't over-constrained to have to check on the babies. The WHO highly recommends kangaroo care, which is prolonged skin-to-skin contact between parent and child to help the infant maintain temperature, remember to breathe, stay calm, among a myriad of other benefits. Enter Biliroo, the first of its kind, patent-pending technology that uses filtered sunlight to treat the jaundice while the infant also receives kangaroo care. Biliroo straps on like a normal kangaroo care sling shown in the image here, and the material properties of our filter enable for the harmful UVA and UVB radiation to be filtered out while allowing for that same therapeutic blue light as before to come through. Our solution is the only non-electric method that combines the two safe, proven, and effective treatments of phototherapy and kangaroo care. In addition to all the benefits, our product can be manufactured for less than 1/10 the cost of conventional phototherapy treatments and even has potential as home-based therapy. Our current team is dedicated to making Biliroo available to the infants that need it the most. Pictured on the left is myself. My name is Daniel. I'm a senior studying mechanical engineering, biology, and chemistry at Calvin. I'm the owner and inventor of Biliroo. I also want to highlight our clinical advisor, Dr. Tina Slusher, who's a physician and a world expert in the field of phototherapy, having done extensive research in West Africa and currently being based in Minneapolis. The rest of the team includes partners in business, medicine, and engineering, and most importantly, on-the-ground physicians in West Africa and South Asia that have provided us with valuable feedback. Our device is patent pending both in the US, and in the past week, we also filed an international patent as well. We have a working prototype and have done some initial user feedback and feasibility research, as well as bench studies this past summer that have shown the efficacy of Biliroo. We hope to publish our data in the coming weeks. As a result of the user feedback testing and 3 international conference presentations, there are many physicians who are interested in using Biliroo. Our product will be economically sustainable. Like I mentioned before, it's estimated that each sling will cost $15 to manufacture and ship, and we plan to sell them at $30 each. We're currently in communication with manufacturers and potential licensing and distributing partners in both South Asia and Sub-Saharan Africa. It's a relatively easy to manufacture device, and so we're researching and networking with established medical device companies to be able to leverage their existing medical device channels and customer bases for our product. Our target customers are hospitals in Sub-Saharan Africa and South Asia because these places have the most unmet need for the device. The clinical trials could lend themselves to being places where we end up being our first customers. We think we may start our venture in Nigeria just because we already have some on-the-ground partners there. And so seeing the stats on the screen, you see that there's so many infants per year that could benefit from our device. And there is a market size that can make this an economically sustainable business. If each sling lasts for 10 uses and it's $30 a piece, that represents a market size of $2.4 million in Nigeria alone. I've talked about what we've done, but the money from this competition would allow us to go to the next step. We want to do clinical trials later this summer and then into next year and launch to market in 2026. And so the funds specifically would be used to manufacture 30 devices for the clinical trials, to be able to coordinate and hire a coordinator for the trials, and then to be able to buy the proper equipment to measure the devices and the clinical trials for regulatory and quality control aspects as well. Together at Biliroo, we want to bring the technology that filters light to the infants that need it the most. We hope that you will help us fight jaundice one baby at a time.
Your device is really only covering the torso of the baby. What's your thought about the head and either protection or being able to target treatment, because that's a large body surfaces from the phototherapy treatment perspective? what's your thought about excluding or including that portion?
Yeah, so we have been looking into that and seeing whether it would be beneficial or not. I know some babies, specifically in South Asia and sometimes in Sub-Saharan Africa, have hair already, and so that might prevent some of the therapy from working. And so right as of now, we've been having the babies have like a hat on while they have the treatment. And based on the irradiance measurements that we were able to find in the bench studies, it looks like the whole surface area of the back and the legs is enough, but that could be a potential future direction if we wanted to make like the filtered sunlight phototherapy available in the head, especially if the infants were bald or didn't have hair.
What is the clinical trial journey like? What are the obstacles you anticipate there?
Yeah, so I'm very grateful to be working with Dr. Slusher on this because she's done previous trials with phototherapy and filtered sunlight phototherapy in Nigeria and Ethiopia. And so definitely great to lean on her expertise. What it looks like for this summer is we're going to do a smaller scale clinical trial, about maybe 20 infants to first demonstrate, that the device works on the infants as expected, and then plan to do a larger clinical trial towards the end of the year. And so that's part of the reason for trying to raise funding for those clinical trials to coordinate them. Thankfully, because we have on-the-ground connections who are at the hospital, who have already stated that they would be willing to help run the clinical trials, that makes our process a little bit easier. And so that's kind of the path we see ourselves taking. And then ultimately, when we go to market, using those connections and leveraging those. So that's kind of the general path we see. The main things we'd be measuring are the irradiance that's provided to the infant, as well as temperature, making sure the infant doesn't overheat, and making sure that the UVA and UVB are filtered out.
Have you thought about including in your device some type of, I don't know, additional device that will say it's enough sun for the device to be effective, and maybe an alarm that will provide the timing that you need? Considering also that this is I mean, if these kids are not treated appropriately, this is a life-threatening condition. So it will be also interesting to know in which parts of the world you can use that, and how much light you need. I mean, this could be used only in summers, but not in winters, depending on where you are, et cetera. So have you thought about that?
Yes, yeah, that's a great question. I think that conveniently the areas where the most need for phototherapy is Sub-Saharan Africa and South Asia, and those areas also do receive the most sun per year. And so that's a great fit with our device. How the device works is it's a kangaroo care sling, and then there's a fastener like Velcro that can bring the filters on and off. And so there is potential if we wanted to also have a battery-operated form of Billy lights. They're a little less effective than sunlight phototherapy, but that could also easily be Velcroed on. As of now, we are working, we have solar-powered sensors to measure the temperature of the baby to make sure that the baby doesn't overheat. And so when they did the clinical trials of just filtered sunlight phototherapy, not the mode of delivery or with kangaroo care, they were able to find that it performed as highly as conventional phototherapy, given the amount of light that comes per year. As long as there's sunlight, you're able to do it. And if there's not, because we have the Velcroed solution, there is ability to have battery operated or solar powered lights that provide the blue lights as well.
Okay, thank you. Hello, everyone. My name is Franol Tashoma. I am a biomedical engineering student from Jimma University, Ethiopia. And today I'm going to share with you the project that we have been working on, PREMI-Up. PREMI-Up is a preterm birth risk predicting AI. As you all know, preterm birth is a birth before 37 weeks of pregnancy, and it is a leading cause of neonatal mortality and long-term health complications like respiratory distress, vision and hearing problems, cerebral palsy, brain developmental delay, and extra. Recent WHO's report shows that 50 million babies born preterm each year, and nearly 1 million of them die, and the rest who survive needs advanced medical attention. 60% of preterm births comes from low and middle income countries. And when we come to our country, the number is even worse. and 11.4% of births is preterm births, and 29.7% of preterm births infants die due to preterm births related complications and due to lack of specialized and advanced neonatal care. So this means that preterm born infants in low resource countries has a hard time surviving this case. So after addressing this problem, my team and I started researching on preterm birth risk factors, and we have identified many risk factors that are related to preterm birth, and we have classified them into 4 demographic and socioeconomic factors. There are different maternal health factors that can lead to preterm birth, behavioral and lifestyle factors, obstetric and gynecologic factor. So the existing predictive methods are like pelvic exams. There are different pelvic exams, transvaginal ultrasound for like cervical length measurement, biomarker tests. But these predictive methods have a huge limitation, like delay prediction. They leave no window for early intervention. Due to their dependency on a single risk factor, they are less accurate, and most of the time they are less sensitive and specific. So in order to overcome these limitations, our main objective is to develop an AI model that analyzes different risk factors for early prediction of preterm birth risk. So this includes maternal data collection, data processing, predictive model development, and user interface development. So our proposed solution is we have collected a different maternal data from different healthcare centers depending on the identified risk factors. So we'll process the data to get high quality data, and we will use AI to develop a predictive model, most machine learning models that are explainable and can be trusted in clinical settings. And also we will use a model explanation in order to identify the relevant factors to preterm birth. And we have developed a web app through which healthcare professionals can interact with this predictive model. This is our main page through which healthcare professionals enter maternal data. This means when a mother comes to healthcare center for routine maternal care, they will collect a risk factor data from a pregnant woman, and they will feed to this model, and this model will give them data-driven risk assessment. So this will help them to identify those pregnancies at risk. So far, we have built a simple model based on the data set we have. We have developed a simple prototype in order to test the feasibility of this model, and the results are quite promising. And our limitation is now we have only limited amount of data set, and we didn't get any fund yet. So our future plan includes collecting large and high quality data, and continuous training and testing the model, and we will look for funding and will patent this model. So we will launch a pilot test program on a selected healthcare centers, and finally we will launch this for a public use. So we believe that Primi app will provide a scalable solution for Ethiopian mothers to improve antenatal care by providing early risk prediction and intervention in order to save a life. So we really believe that the pregnant woman who lives in a poor countries will get early risk prediction and intervention in order to prevent preterm birth related infant mortality and morbidity. And we would like to thank you, Rice University, for providing this opportunity, and our university for giving us a resource to develop this application.
Hello, ladies and gentlemen. This is Team Wound Care Innovators from Makerere University, and we have developed a low-cost negative pressure wound therapy device for accessible wound care in low-resource settings. So meet Dr. Brian Kasaga. Dr. Brian is actually a resident surgeon at the Chirudu National Referral Hospital, and he has treated patients with diabetic foot ulcers, pressure ulcers, wounds from burns, and he says that doctors and nurses always try their best to manage these wounds with the available resources, but there is a problem. Wound management is effective, but it is very expensive for most hospitals and patients in Uganda. And since doctors rely on basic wound care methods like the regular dressings, healing is often prolonged, and that puts patients at the risk of developing infections, which can escalate into sepsis and amputations for some. Some patients even end up dying. And the hospitals also are overwhelmed by these long inpatient stays for wound patients. And on the other hand, the more patients stay in the hospital is the more they suffer, both physically and economically. And this is just part of a much bigger crisis because annually, approximately 14 million people suffer from wounds globally. And 80% of these cases are in low and middle income countries like Uganda. But the good news is negative pressure wound therapy has potential to revolutionize wound care because studies show that it can actually reduce healing time by over 50%. And despite this efficacy, it isn't widely used in LMICs. Why? The commercially available devices are very expensive. They cost over $3,000, which is unaffordable for many hospitals. Then there is this dependency on single-use consumables, the unstable electricity supply, and then the complex user interfaces. Plus, many of them are either donated or imported. So when they break down, they cannot be repaired or replaced locally. They are just abandoned. So in light of these challenges, we sat down as a team and asked ourselves, how can we help Dr. Brian and other doctors in LMICs improve wound care? That is when we decided to design, develop, and validate a low-cost wound care solution that can actually work in low-resource settings. This solution we are developing had to be affordable, with a cost not exceeding $100. Then it also had to be portable and able to function even in the absence of electricity. It had to be able to deliver an adjustable pressure range and alert users in case of any errors, but it also had to be easy to use because in the end, the goal was to design for impact and not for complexity. And now, ladies and gentlemen, allow me introduce our TheraMark device, a low-cost, locally developed negative pressure wound therapy device for LMICs. So TheraMark basically comprises a microcontroller that contains the control algorithm. It also has a display screen. It has a suction pump that provides the negative pressure, and then the pressure sensor that works in sync with an alarm system for feedback. All of that is housed inside the custom acrylic casing. And this device can actually operate on power from the mains or battery, and it is also solar compatible. So to use the device, the wound is first cleaned and dressed with sterile gauze, and then sealed with polyurethane film to create an airtight seal around the wound area. So after the values and durations of the maximum and minimum pressure have been set, the pressure sensor detects the wound vacuum level and informs the algorithm to control the pump in order to maintain the set pressure. So the timing cycles will alternate between the minimum pressure and the maximum pressure. So in the end, exudate will be drawn from the wound through the silicone tubing and then drained in the canister. Our proof of concept tests show that the device can actually provide an adjustable and stable pressure range between 25 to 175 millimeters of mercury, and its error response is quick with a fully functional alarm system. And most importantly, every part we used was locally sourced, and the bill of materials was around 410,000 Ugandan shillings. That is approximately 110 US dollars. But we know that with mass manufacturing, those costs can be further cut. So all this makes TheraMark stand out from other solutions because it reduces healing time, it is affordable, it provides an adjustable pressure range, and it is locally available. So we are confident that this positions it well to improve wound care in LMICs, which will lead to lower mortality rates, improved surgical recovery outcomes, and also reduce the burden on our health systems, but above all, ensure equitable access to advanced care. So part of our next steps include benchtop validation, where we'll test the effectiveness of the device and get user feedback. We will then partner with local manufacturers to manufacture some samples of the device and head to clinical trials such that we have the device onto market by December 2026. So with clinical insights from our clinical client, Dr. Brian Kasaga, TheraMark was developed by a team of biomedical engineers from Makerere University, and we know that by reimagining wound care through frugal innovation, we are not just lowering costs, we are raising the standard of care where it is definitely needed most.
I have a question, maybe something we also struggle with in our lab. How do you make it solar compatible? That is a very good move. And also, how long does it use batteries? And have you been able to incorporate that into your device? Thank you very much.
The device can operate on power from the mains and the battery. So in case there is in case there is electricity, we have a system that a battery management system, power management system, it will prioritize the power from the mains. And as the device is operating from the power from the mains, it will be charging. We have a rechargeable battery, so it will be charging the battery. So in case this power from the mains goes off, the device will stay running using power from the battery. And also, we made sure that we have a solar control charger that in case there are areas where the hospital is using solar, they will still power the device using that solar and it will still charge the rechargeable battery. In case the solar energy is depleted, they will then switch to power that is coming from the battery.
What are some of the limitations you see in your current progress?
Yeah. All right, some of the limitations we are currently facing is there are some tests we really have to do and to further validate the efficacy and effectiveness of the device, but we do not have the tools at the moment to carry out those tests, and also the facilities from where to carry out those tests from, plus the funding to carry out those tests. So that is part of why we applied for this competition, so that in case we get the funding, we tackle some of those challenges first, go on to test the device, and then ensure that every aspect of it is 100% effective before we send it onto the market. And then for the aspect of going onto the market, we plan to partner with local manufacturers, local medical device manufacturers that are certified to manufacture these medical devices in Uganda, and see that we negotiate a way on how we can manufacture this device with them, and also partner with the national medical device suppliers like the national medical stores, the joint medical stores. But then all that will be after carrying out clinical trials to after we have the concrete validation of what we really hope our device is doing.
Every year, sepsis affects 49 million people across the globe, and it leads to 11 million deaths. Sepsis is the body's extreme reaction to infection or injury that causes decreased blood perfusion and can lead to organ failure, tissue damage, and death. Sepsis can affect anyone. However, 80% of these yearly deaths are preventable with timely intervention and continuous tissue perfusion monitoring. Measuring tissue perfusion is essential for survival, as every hour without proper care leads to an increased mortality risk of 4 to 9%. Clinicians currently do not have an objective, real-time way to identify sepsis in the emergency room or a way to track tissue perfusion status at the bedside for admitted patients.
Capillary refill time, or CRT, is an ideal metric for real-time tissue perfusion monitoring and decision-making for sepsis patients in the hospital. Currently, clinicians measure CRT by applying a pressure to the fingertip for 5 to 10 seconds until the finger is blanched, and then releasing and measuring the time it takes for the finger to return to its baseline color, or in this case, 1.81 seconds. As you can see in the video, CRT is non-invasive, quick, and easily measured at the bedside. However, manual CRT measurements are subject to significant variability, specifically in low light settings and in patients with different skin colors. Pulse ox can eliminate these shortcomings. This is a normal pulse ox waveform. When a patient's finger is compressed, the waveform flatlines. After compression is released, we can calculate the CRT as the time between the end of the waveform flatline and the return of the waveform baseline. While pulse ox has become the gold standard for measuring CRT, there is a need to improve CRT measurements. Currently, there is nothing on the market that can intermittently take standardized, patient-specific, and automated measurements. Our device Prime, or perfusion refill indicator for monitoring efficiency, automatically compresses a patient's finger using a blood pressure cuff and provides continuous CRT measurements at clinician-determined intervals. Our device will be one of the standard devices that septic patients will wear in the ICU. Since septic patients are already connected to pulse oximeters, Prime will easily fit into the ICU workflow and decrease provider burden. Prime will also be used in the ER as an evaluation tool to detect sepsis and allow patients proper treatment. When designing our device, we kept 6 goals and need specifications in mind. Number 1 is low cost, because ICU spending is already high. Prime is under $200. Second, devices must be compact to avoid interference with other hospital equipment. Prime is below 9 by 6 by 6 inches. Third, it must easily integrate into existing monitors. We use a pulse ox that is widely available online. Fourth, devices must be sensitive and track changes in patient CRT. Prime can detect 0.2-second changes in CRT. Lastly, Prime automatically takes intermittent measurements to reduce clinician burden and track changes in CRT over time. Prime can take measurements as short as every minute.
Our device uses our automatic compression mechanism uses a neonatal blood pressure cuff with an air pump and a solenoid valve, and a pulse ox that sits on the cuff and allows us to collect real-time data. This data is then processed on a Raspberry Pi and can send information to our PCB to turn on or off the air pumps, allowing for a customizable loop. This allows us to use real-time data from the pulse ox to influence our algorithm. We detect a flat line in real time from the waveform using the standard deviation and turn off the pump. We then collect the pulse oximeter data to find the next defined peak and calculate CRT and update the user interface with the data. On our user interface, we display the CRT measurement, the time the measurement was taken, as well as the change from the previous measurement. We also allow clinicians to customize a measurement interval and start the device. We display the oxygen saturation as well as the pulse ox waveform, and finally, the clinician can stop and export the data. Additionally, our device uses a text alert system to let clinicians know when a patient's CRT has changed significantly, which, as mentioned previously, is above 0.2 seconds.
To account for the differences in patients, we tested Prime on 18 subjects with varying skin tones and finger sizes, and we had 3 clinicians to measure CRT manually. We measured CRT 3 times using Prime and manual measurement and found that for all subjects, Prime produced CRT values that were closer to each other, indicating that it's more precise than clinicians. Additionally, we found using an interclass correlation coefficient that Prime is more repeatable than clinicians. It scored 0.92 in comparison to 0.78. To mimic slow tissue perfusion in septic patients, we placed a manual blood pressure cuff on the subject's upper arm and inflated it to 300 millimeters of mercury, then measured CRT using Prime. For all patients, a statistically significant difference was observed between normal and delayed CRT. Prime meets all need specifications. And there are 3 future steps we would like to make. First, the device is not compatible with hospital records, so we would like to work with hospital systems to ensure that patient data automatically updates in patient charts. Second, the device is currently very sensitive to movement, and we plan to make it more stable. And finally, the device has only been tested with patients and not clinicians. We would like to conduct a usability studies for clinicians to determine any operational challenges and evaluate the ease of use. Prime has the opportunity to revolutionize patient care because every second matters. We would meet our team and would like to thank our mentors, and we're happy to take any questions.
I wonder why, in this circumstance, you used a Raspberry Pi when it would seem that a microcontroller would be capable of computing everything that you needed to compute, which would lower the cost a little.
Yeah, that's a great question and definitely something that we're looking into in the future. For now, we knew that we only had the fall semester up to now to design something, so we wanted to use a device that we were fairly comfortable with and knew that we could test our compression mechanism and just how to calculate CRT in a very quick way.
Great presentation, agreed. The data part is very clear. I have a question about your problem statement. Do you envision this device to be used in what setting? For diagnostic, predictive, prognostic, or therapeutic purpose? I wasn't quite sure. Maybe I missed it from your beginning presentation.
Oh, absolutely. So we envision the device being used in 2 different settings. Septic patients present at all different parts of a hospital's workflow, and so our device, we envision it fitting into all those different pieces. Right now, we're targeting 2 main areas of intervention. First being the emergency room setting. So patients often come into the emergency room and have to wait for hours, and this delay in treatment leads them to becoming very sick and potentially passing away. And so we do envision the device being used as a diagnostic during triage in the ER, where when a patient is getting their vitals taken, they can also have their CRT measured, and we can make sure that their CRT is not too high. And then secondly, being used for admitted patients on the floor, there's currently no way to track tissue perfusion status easily at the bedside. And so with a patient who's already connected to a pulse oximeter, we can put our device on and it would intermittently measure and it would alert clinicians when a patient's status declines.
I will put a word of caution, okay? So this measure actually is used mostly by nursing as a way of seeing how well perfused the patient is, okay? And actually, we don't use it as a diagnostic tool. And by the time a patient has an elevated one, we know that the patient is very sick. So, and probably one of the settings in which it could be used mainly is the ICU. However, that's another thing that, we are always concerned, with the pulse oximeter, patients that are stayed for a long time with the pressure end up having damage of the nerves and other things. So I wonder if you have considered also that issue about the pressure, continuous pressure, et cetera. So I think it's a quite interesting tool that could make things a little bit more objective than just touching the finger. You're right. But it has its limitations. And talking about diagnostic and therapeutic, it's a monitor tool.
Yes.
Okay, so you have to be very careful about it and think about the pressure, because several times something that is there in the finger, it's not seen and could, after the patient recovers, it could be really, really a problematic issue.
One of the things that research has recently come out and showing is like some of the things that are typically used, like serum lactate measurements, for example, have less specificity than capillary refill time can have. And also additional measurements and studies have shown recently that capillary refill time can be used as a more accurate predictor of sepsis. However, the issues with it that we outlined in our presentation do exist. We definitely do think that the ICU would be a good place for us to start, and have heard that a lot of ICU clinicians do think that this could be helpful. And I'll let Sophie address things about the pressure.
Oh yeah, I think in terms of pressure, we really wanted our device to be customizable to a clinician. And so that's also why we allow the clinician to set the specified interval, where if there are concerns that the pressure is too much, maybe you can reduce the interval to every 30 minutes instead of every 5 minutes. And then after that, maybe you have to start exploring more invasive options.
Every heartbeat deserves love and safety. We are Team Guardians, here to share our story that touches the heart. As a biomedical engineering intern at the Lagos University Teaching Hospital, a young expecting mother was rushed into the healthcare center. She was bleeding severely. It was diagnosed that she had preterm labor and was rushed into the emergency center. She lost her baby in the process due to birth complication and narrowly survived death. This and many more happens to several women across Africa. After much findings, we discovered that it was due to leaking of amniotic fluid leakage, a condition that was not diagnosed early enough, leading to preterm premature rupturing of the membrane, PPRO. According to statistics from the World Health Organization, PPPROM account for 40% of preterm births, leading to maternal and neonatal deaths. We need a solution that can be able to fit into local, low resource settings. It has to be affordable, portable, easy to use, non-invasive, while giving accurate results. Yes, that was why we created the AM detector. It is a simple device that can be used at home and in the hospital to differentiate between the amniotic fluid leakage and the normal vaginal discharge, helping us to discover problems early enough. Our device was able to meet up with the design criteria. These features helped it to become affordable, cost-effective, portable, easy to use, yet giving accurate results through our calibration of our sensors. I'll be calling on my next team member, Emmanuel, to talk on the next sessions.
Thank you very much, Joy. So this is how our device works. As the user, you just need to use the swab to get in touch with your vaginal discharge. You put it into the sample area, the sample chamber of the amniotic fluid detector, and then it does its auto test and then show you your results. This is the phase when we were doing our prototyping, and this is our 3D printed material. This is how the device works. This is its working principle. When it detects the fluid, it scans for the pH. There is a range for amniotic fluid pH, which is between 7 to 7.5. If it is a yes, it does a conductivity test for accuracy. If the conductivity is high, it does a dryness check. The dryness check is because of the Fenner effect of the amniotic fluid, which takes it a longer time to dry up. If that is a yes, then it goes and it confirms that that fluid is amniotic fluid, and it displays a possible PPROM, helping the mother know that she needs to get to the hospital to get checked. But if the cases here are no, in all of the instances I've mentioned, it will ask you to do a retest. And if from the pH point, it does not fall within the range of 7 to 7.5, it tells you that there is no amniotic fluid. So there is no need to be bothered. This is what makes us different. The amniotic detector is different because it is low cost, just like Joy said. It is affordable, it is portable, you can carry it anywhere. And we are using several biomarkers to check, which ensures that our results are accurate. We have a 90% accuracy. Then this is made for non-medical users. Anywhere you are, in rural areas, low resource setting, you can always use the AM detector. You need no technical know-how. This is our progress so far. We've been able to do our prototype, and we've been able to do clinical trials due to our partnership with the Lagos University Teaching Hospital. We also partnered with the Unilag Design Studio, where we built our device. Then we've been able to validate that this device can work based on our trials and the prototype we have. The challenges we encountered was the fact that we had limited access to advanced manufacturing equipment, and the fact that some of the components we used were not locally made, so we had to import them, and unstable power supply and poor internet connectivity. But we've been able to overcome that because we now have our device and it works, and here we are. Our market strategy is that we have our target audience, and our target audience includes the midwives, the governments, NGOs, and any mother, any pregnant mother out there who is looking for a easy means to know if there is need for her to quickly go to the hospital and prevent miscarriages or deaths of even the mother herself. So we have a revenue model, which is by purchase. You have to pay to get our device. We are partnering with stakeholders who are interested in investing in our solution. And then with that, we are ready to market. Our future improvement is that we plan on having an enhanced analysis by AI integration. We want to build a mobile app which will help the mothers to keep track of all of their results and ensure that they have a good idea of what their discharge has been over a period of time. Then we also plan to do further clinical trials so that we can go to the market fully. Then this is the team. I am Emmanuel Awolowo. I have Joy, who spoke earlier. I have Orobosa, I have Bright, and we have Shalom. And together we are Team Guardian. Thank you for your time.
What happens, what intervention is available if you find out that your amniotic fluid is leaking? That's one. And also, what is the size of the actual prototype? You went very quickly through the 3D printed prototype. Thank you.
What we have in mind is to inform pregnant women early enough so that they can go to the nearest available hospitals or clinics in their community, in their area. And for the size of the prototype, this is it here. And this is about 180 for the length, and then 60 to 80 for the breadth.
180 millimeter.
And then 80 millimeter.
I'm a physician, and so it's important to know if something that is coming out from the vagina in a pregnant woman is amniotic fluid. And actually, several times what happens, especially in low-middle-income countries like mine, I come from Peru, is that when they get to the primary care, what happens is that you get a swab and you put it in whatever fluid is coming, you put it on the slide, and then you see if it forms like a fern leaf, right? And that means that that's positive. And then you know that depending on how far the pregnancy is, you have different risks, and you have to see if you're gonna control the pregnancy, be sure that they don't get an infection, or, because that's the biggest problem, that the baby can be lost or there could be an infection. So what you are saying is that this device could be used by the mother in their houses. However, I know that this is a prototype, but so it is kind of, and maybe that will relate to the costs. Are you thinking about making this a much simpler thing that could be really deployed at the community level? Because that's probably what we need. We need a pregnant woman that could go home. The midwife could give her something. It's like at any point you see any vaginal discharge, just use this. I can imagine it as a strip, right? Use this, and if it turns some color, then you come immediately. Have you thought about moving into that direction? Because that will really be something that will be a change and will really help women. So how would you move into that?
Yes, Ma, we are currently looking into that too. Our device is going to just use the swab. It is kept on swab chamber. The pregnant woman can see her results, and it would make her to know whether she should go to the hospital or if she should not worry about it, that if it is not an amniotic fluid. So it's something that is reusable and easy to use. My team member Emmanuel will still talk more on it, Ma.
Okay, thank you very much. To add to what Joy said, we would have loved to present right now because we have some improvement on our current slides, which explains a lot of the questions you just asked. But unfortunately, we have a downtime here and we couldn't present. If the opportunity is presented to us, we would be glad to grab it. But then the idea behind this is for test strips, they are not reusable. But we want a device that the woman can have and have for a very, very long period of time. So we have several sensors. The first thing we are looking for is the pH, which has to be within the range of 7.1 to 7.4. And then we are looking at the conductivity because amniotic fluid has a higher concentration of ions. So if it is high, because we are using a conductivity sensor, it kind of confirms what we've already confirmed from the pH. And we didn't stop there because we want to be accurate, that we are not giving false positives. Then we brought in the dryness check. Because of fanning effect, it takes a longer time for the amniotic fluid to dry up. So there is a sensor we have here that checks how long it takes. When it is wet, the temperature remains cold. When it is dry, the temperature is kind of higher. So we look at how long it takes for it to dry up. If it is about 2 minutes, which is that for the amniotic fluid, then we have a confirmation that, okay, this is amniotic fluid. Possible PPROM, seek medical care. So we are very, very particular about early detection so that we don't lose people. In our storyline, we have Aisha. We believe that if we can save Aisha, then we can save a lot of mothers out there too. Thank you.
Good morning to everyone. We're Team Borbojito. We are biomedical engineering students from Peru, and one of our missions is to find solutions to medical problems. One of them is glaucoma. So we created Borbojito, which is a mix between the words in Spanish bubble and eye, which is a portable campimeter for the detection of glaucoma in rural areas. We want to create a campimeter as fast as you create a bubble. So the glaucoma affects people with the progressive loss of visual field. It affects 76 million people all around the world, and it's expected that in 2040 will affect more than 100 million people. Glaucoma in Peru accounts for 13.7% of blindness cases. In people over 60, the prevalence rises to 14%. A remarkable thing in Peru is our centralism. As a result, most professionals are concentrated in the capital and leaving other regions unserved. As an example, in 2019, only 2% of the 1,500 ophthalmologists in Peru worked in rural areas. also the devices that are used to test the visual field of patients, the campimeters, are big, heavy, fixed, and not portable. They cannot be transported to unsuitable areas, and also very expensive. So here comes our solution, Burbojito, which is a portable, foldable, and accessible campimeter. It's made with arcs, C-shaped arcs that are capable to be foldable. Also, it has a forehead and a chin rest for the patient's head, a thread system for height adjustment, and the bottom for the answer of the patients. A regular campimeter can cost around $6,000, and Burbojito has a cost of around $70. Normal campimeter uses light stimuli to detect where the patient can or cannot see. So the arcs of Burbojito are joined by blackout fabric that has integrated 52 lights using the CETA-FAST 24/2 protocol. So the patient can press the button and it will show us if they see or not see. It's linked to a mobile app where patient data is entered and all the data transforms into a PDF where all the information is showed to the physician. The physician can access to a web page where he can see all the reports of all the patients and give a diagnosis. So one person can be getting data here, and a physician from the capital can give the diagnosis. This is the folding mechanism. This is our first prototype. That's how fast you can create the campimeter with Burbojito. And this is the light stimuli. It has 5 intensities to check how can a patient see in that place.
This prototype integrates an infrared eye tracking system that allows us to monitor the eye movements of the patient in real time. If the user looks away from the central fixation point several times during the test, this test is canceled and restarted to ensure accurate results. The data is transmitted via Bluetooth to both the mobile app and the web platform. Compared to, as we said before, compared to traditional perimetry systems that cost over $6,000, these designs offer a much more accessible and functional alternative. The technological integration is achieved through the mobile app that can collect the data from the device and generate a report that can securely transmit it via Bluetooth to the medical specialist. Additionally, the web platform allows ophthalmologists to remotely access and visualize the test results, that way supporting the diagnosis decision-making from anywhere. Burbojito generates a complete report that includes the patient's information, global indexes, and reliability indexes from the test. This data is associated with the different conditions such as early glaucoma, optical neuropathies, strokes, and macular degeneration. As part of this project, we're also investigating the relationship between these different conditions and the percentage of visual field loss together with the areas where these start. And it's also taking into account risk factors such as age, previous medical history, and medications that the patient is taking. This supports a more accurate diagnostics, and the ophthalmologist is capable of recording the diagnosis on the web platform, and that way it can be shared with the patient. Burbojito was developed with a particular focus on the ease of use in rural areas. Its portable design and the simple deployment makes it ideal for settings with limited medical infrastructure. As it requires minimal training, it's effectively used by non-specialized personnel. The potential impact that this project can have is substantial. It can improve early glaucoma detection, enhance access to vision care in underserved communities, and contribute that way to reduce preventable blindness. Imagine a world where early glaucoma detection is accessible to everyone, everywhere. With Burbojito, we're turning this vision into a reality, one eye at a time. We have the support of the different ophthalmologic societies in Peru, and also we're participating in other Congress of Ophthalmology, such as the Peruvian Congress of Glaucoma this year.
how are you determining that it's not reflected light within the eye that the person is able to detect versus the specific visual field?
This is more of an artifact of the recording process. The lights are point source, the stimuli are point source, and together with this device, we also have like a kind of hood that goes over the patient's head. That way, there's no so much reflection.
Blackout fabric to avoid that. So with the hood and also the computer all closed without any light interrupting, all the light stimuli does not reflect in other locations of the computer.
That helps, yes, but there's also a one point of improvement from the design. As you can see in the video, there's a lot of shadows that appear, especially from some of the angles. That's something we're working on.
Congratulations, this is quite interesting, and it's great to see people from my own country presenting here, so I'm really proud. I have a question for you. How have you measured the accuracy of this device compared with the standard of care? Okay, have you planned to do any studies? I mean, because it looks great, but have you compared like the same patient and the diagnosis that you are made with what happens with the standard of care? How are you in that process?
And yes, we haven't done clinical trial tests yet, and we are working with INO. We are doing the coordinations to be able to do a test, compare our results against professional perimeters using the clinical environment, but it's still something we haven't done yet. We have only done tryouts with other students and by ourselves in the team. Another thing that we would like to mention is that as we mentioned, we are implementing a camera for the eye tracking, and other professionals have asked us why we are not, or if we already have a camera, why not use it to take pictures from the eye. And it's a good question. And the reason why we're not doing that is because it increases the use of the eye dilating drops, increases the cost of use of the device by, I think, 300%. And that's why we didn't go with that approach.
Hello everyone, we are Team Manuvera from Bangladesh University of Engineering and Technology. I am Sunaina Rahman Adisha, joined with Afroza Yasmin Isha and Rudmila Nizam. We are here to present our prosthetic arm-based project which uses nitinol actuator. The global concern that our projects aim to eradicate is amputation. Amputation is a rising global concern with 13 million new cases each year. Among them, 30% are children. Children face some additional physical, psychological, and social challenges apart from adult amputees. Let's break down what additional issues child amputees face. As they grow, there is a frequent need of replacement of prosthetics, which often causes a financial burden to their families. Again, most prosthetics are high technology dependent, which makes them hard to access and maintain. Myoelectric and body-powered prosthetic needs long-term training session, which is difficult for children. Children needs more comfortable and skin-sensitive design, and most importantly, they are appearance sensitive. So if it feels like machine, there is a high possibility that they will reject it. The current existing solutions are passive limb, which costs $20,000 to $5,000 US. It offers only cosmetic appearance but no functionality. Body-powered prosthetic cost $10,000 USD. It shows some functionality but needs sufficient effort, physical effort, which is difficult for children. Again, myoelectric prosthetic cost $20,000 to $100,000 USD. It is high expensive and needs a long-term training session, which is very inconvenient for children. Our nitinol-based prosthetic arm uses smart material nitinol actuator, which is a shape memory alloy. It is lightweight, customizable, so easily replaceable, and it is affordable, costing only $30 to $40 US. For ensuring inclusivity, we have made our design gender and age neutral. It is designed for low-income underserved children, and it can be made with low setup in locally available materials, and no advanced factory is needed. Here is a prototype of our design. It has 6 parts: upper arm, forearm, nitinol actuator, palm, ligament, and phalanges. Though it is specially designed for children, it can be customized for all ages. For our first trial, we conducted the trial on an adult person due to ethical considerations, as children cannot give their consent. We trialed on a below elbow amputee. Here is the video of our amputee. And previous slide, please. And the belt prosthetic is attached with the amputee with a Velcro belt with upper arm. Next slide. For controlling the nitinol actuator, we have used flex sensor. When the elbow is bent, flex sensor is bent, current flows through the nitinol actuator. Nitinol actuator heats up and it contracts. As a result, the fingers are closed. Here is the video. Again, when the elbow is relaxed, flex sensor is relaxed, current stops flowing to nitinol actuator. Nitinol actuator cools down, and as a result, TPU ligament pulls down the fingers open again. Here is a demonstration video, picking things. It can have a minimum peak of 3 centimeters. Here is the video of our amputee working with the prosthetic arm in his fruit shop. Our design meets all the problems stated before. It is affordable as it costs only $30 to $40. It is custom fit, so easily replaceable. It is lightweight, only 310 to 410 grams. It is easy. It is child friendly with no pain or injury risk, and it can be made with locally available materials with just a 3D printing machine. Here are some success of our project. We have already tested tensile test, hand dynamometer test, and functional test. The forces require only 30 Newton to 60 Newton. We have successfully trialed on an amputee. We have published a paper in IEEE. It is low power consumption, only needs a 5-volt DC battery, and it is environment friendly. Still, there are some drawbacks of our project. For example, the lifespan of nitinol actuator is 1 to 2 years, so it should be increased. The nitinol heats up to 35 to 40 degrees Celsius, so proper insulation need to be incorporated. And for customization across all age groups, streamlined production is needed. In future, we aim to enhance the functionality of nitinol, expand our trials on different amputees and different age peoples, and we want to distribute our project as open source. We plan to publish our STL files, Arduino code schematics in a GitHub repository. We have already launched a YouTube channel and published our paper in IEEE.
One question I had on the things I didn't notice. Do you have, as far as your battery or powering the device, and how long does the battery that you use last, and what sort of a power consumption is there for these actuators?
Thank you for the questions. Yes, we have used a rechargeable DC battery. It lasts for 7 to 8 hours, and we can recharge it.
Hi, really cool product. Exciting to see you guys use it in action. I had a question about the grasping forces you're able to achieve, and what use cases you imagine someone using your prosthetic use it for, in terms of what they're trying to pick up and move around.
Thank you for your question. For picking up things, we have distributed the force into 2 sections. Like three fingers need 60 Newton force, and other 2 fingers need 30 Newton force. This force is not needed by the amputee because it was gated by the nitinol actuator exactly. The patient, the amputee don't have to put any effort to do the grab, and it can pick up minimum 3 centimeter.
Awesome, thank you.
Oh, right behind you.
Sorry.
Yes, so you guys mentioned that you're trying to focus on underserved or children underserved populations, right? I'm just wondering how you foresee 3D printing being an accessible form of manufacturing for people in those populations.
Okay, Thank you for your questions. We have thought it in our country's respect. Our country is Bangladesh, which is middle economy country. So a 3D printing machine costs almost in our country 1 lakh Bangladeshi taka. That means 1,000 USD, and through it we can made up to 30 hardwares per day. So if in our country the total cost will be 30 to 40 US dollar per unit. So only just a 3D printing machine, which is accessible in low income countries like our country, we can made up the whole thing in a country and serve up to 30 to 40 units per day.
I had a question more on the technical side of things. I know when dealing with nitinol, you have to allow the wire to cool before actuating again. I had a question about if you guys have tested repeated actuations in succession and how that, if that's possible.
It can be actuated again because when the flex sensor is relaxed, the current stops flowing to the nitinol actuator. The nitinol actuator is cooled down, and we have used TPU for ligament. So when the nitinol actuator is cooled down, the TPU ligament pulls it back to the previous position. So the fingers are opened again, and nitinol actuator is put in the previous length again.
RSI, a portable retinograph. This is the way that we should see the city of Cusco, but unfortunately there's an illness that steals our visions and makes us to see this way. So in the world, 80 million people suffer from glaucoma, and its late diagnosis has led it to be the second cause of blindness in the world, and also in Peru. So in 2022, glaucoma was one of the most diseases on outpatient ophthalmology department at the regional hospital of Cusco. So the situation in Peru is very critical because about 80,783,000 medical posts are in inadequate conditions. So that is the hard thing. So actually our need statement is not the lack of technology, but rather is the lack of access to the technology, and also the trained people who can operate that device. So that's why our need, based on our need statement, we list our requirements that are portability, accuracy for early detection, not invasiveness, easier use, low cost, and patient comfort. So these requirements aims to overcome all the challenges of this situation.
To evaluate existing technologies, we have made this table. We have defined two edges, the level of complexity and the level of importance. We want a solution to be less complex for us to implement it, but it has to fulfill with the requirement criteria. We have been analyzing several solutions as OCT and gonioscopy, but they're huge, big machines, and they're so difficult to transport them to rural areas. And yeah, that we have test some of this device, and yeah, we have to be aware that this is portable for transport. So that's we look at tonometry, campimetry, and retinography, and we realize that retinography has the most of important information and features for the medical specialists, but it's still expensive. So that's we propose ours. Our device that fills all the gaps. Horus as a solution concept is a portable retinal camera that is designed for early glaucoma screening. And yeah, it can be understood as the interconnection of 3 blocks. You have the hardware, the software, and the telemedicine protocol with AI processing. Here we have some features and our render model, exposure view, and we also have a step-by-step, because you're asking, how does it work? Yeah, first we have the user registration through our app, then the login part, then we enter the patient data, contact, or anything else, then we start the test, and we connect the device via Bluetooth to the physical part. Then we positionate the device, like align it vertically and horizontally, and we position through the patient's eye. Finally, when it's all ready, we take the picture. And yeah, we validate our model with an eye trainer made by Hain. This could allow us to see our device through different pupil dilatation apertures, 8 to 3 millimeter. 3 millimeter is the close natural pupil size. And yeah, it's harder to take the picture when the pupil is very close. And yeah, we also take this validation with myopia and hyperopia conditions that are so common in the people. And yeah, with that conditions, the image gets blurry. Yeah, you can see the image on below. Then we have the results in humans. We have tested in humans in non-mydrotic conditions and mydrotic conditions. In mydrotic, we have to apply some drops to the patient that is not comfortable for the patient, but for us, it's easier to get the picture. And in non-mydrotic condition on the other side, it's a natural take of the picture. Well, we take a lot of time for taking that picture, but yeah, we could.
Today, a process we base our code from an open source database and to the Chinese database. This code segmentates the disk and the cup and also extracts three main features, the CDR, DDLS, and ISNT. Let me explain you about this feature. With these key parameters, we can identify and predict the stage of the diagnosis of the glaucoma. The CDR is the cup to this radio, is a relation between the cup, which is the yellow part, and the disc, which is the orange part. With increase this ratio, is increase the probability to get glaucoma. The ISNT, superior nasal temporal, follow a specific rule to be considered a normal eye. And also, and this damage likelihood scale, say that below 0.3, considered a glaucomatous eye. So we show you one of the AR results. We have the fundus image, the optical disc, and the cup disc segmentation, and how this mask can overlay the fundus image. We can see a CDR for moderate glaucoma, and ISNT that deviate from the rule, so it's a suspicious behavior, and also a DDLS below 0.3 that confirms that we are treating from a glaucomatous eye. So the successful for iReside is portability, because allow to go all health campaigns and bring more close the technology to all communities. Also, it's lower cost, that it's only $75, 93 times cheaper to commercial fundus camera, standard from the cost relation ratio, and also the limitation we found about it is that we need to use mydrotic drops to obtain a reliable fundus image. The AI was based in China database, and also the future plan to do is to improve the optical arrangement to can do the procedure without the mydrotic drops, and also take and retroaliment the AI with fundus image taken for Peruvian population. This is our team, and we want to go to our side to fewer Peruvians can lay diagnosis to in rural areas. Thank you very much, and we are welcome to your questions.
Anyway, so this is quite interesting. I have only two issues. So one, it's good that you have found some data from the Chinese already trying to measure the size of the optic nerve and how does it relate to glaucoma. But remember that glaucoma is the increase of pressure in the eye. So by the time we have already engorgement of the nerve, you are having much more advanced disease. Okay, so what I see is that you have additionally something that you could use. I mean, this is kind of like a machine for, it's like a retinography, what you are getting.
Yes, it is.
So actually, you can use this not only for glaucoma. This could be quite helpful, for example, for diabetic retinopathy, for detachments of the retina, and any other issues. So actually, you have the possibility. So what I'm doing is I'm increasing the kind of things that could be used if the images are correct, and if you are able, of course, to detect, and I'm sure that there are algorithms already for the reading of eye retinopathy, okay? Because the machines do that for the doctor, the most expensive ones. So probably to make this even much stronger, I suggest you to increase the utility of the device that you have made that is very low cost, and that I think additional together with the campimetry, I mean, they both can be excellent tools to improve screening in rural areas. So, bravo.
we think that we can go beyond not only for glaucoma disease, but we can extrapolate the data from retinopathy diabetes, as you say. But now our stakeholders are persons who live in rural areas that don't have the access to this technology and don't have the personnel to take this retinography. So we want to fill that gap with IROSI.
Great presentation and nice solutions. And I agree with the comment about the potential application of your technology. It would be great for you to really articulate what that problem is. You started out with the problem of glaucoma, but obviously, the access to expertise and technology is common across other eye diseases. But the specific question to your solution that I have is, have you looked at, not the accuracy, well, have you looked at how, at what stages of disease your technology is performing at the level that really can help detecting glaucoma? Because again, is it early, mid, late, and have you done the clinical study or at least the research in the laboratory to see what segment of the patient population the solution is best targeted to?
We, based on the literature, there's, as I showed you before, there are tables that you can see based on the CDR number, if you have a mild glaucoma, severe glaucoma. So these key features help us, the doctor, identify, because this mass will send out to the doctor to give the final diagnosis of the person within 3 days, which is a lower time for the actually it's. So yeah, we are detected in the early diagnosis, even more early than the campimetry can do.
Hello everyone, good morning. So we are Team Scope is from Bangladesh. I'm Saurav and this is Mahi. So we are here to present our solution to a critical challenge in airway management system, which is development of an affordable video laryngoscope. So our goal is simple yet vital to create to improve patient safety and training efficiency by making video laryngoscopy accessible to all. So what is laryngoscopy? Laryngoscopy is a medical procedure used to visualize the larynx and the upper airway. It has a wide range of clinical applications. It assists in intubation during surgeries and emergency situations. It helps to diagnose airway obstructions, and also it aids in the assessment of any vocal cords and laryngeal disorders. While laryngoscopy is a routine yet essential medical procedure, but it comes with some significant challenges. Each year, over 13 million intubations are performed globally. Among them, 10 to 20% intubations are considered difficult. In trauma cases, the risk is even higher, increasing the chances of airway trauma, cardiac arrest, and hypoxia. Pediatric patients faces even greater danger. Up to 8.5% of the children, for children, failed intubation occurs. So in many low resource settings, doctors still solely relies on laryngoscope blades. Though this tool is functional, but it has some serious limitations. It doesn't offer any visibility option which makes it difficult to which makes it harder to navigate those difficult intubations, and finally increases the failed intubation rate and other complications. Also, without any screen, there is no option to record or review the whole procedure. So while designing our device, we have kept 6 key priorities. Firstly, affordability. We designed our device under $100. Secondly, clear visualization of the airway. 34 compatibility, we kept dual display options for our device. And for material choice, we used PLA for its biocompatibility and patient safety options. And we have also kept recording capability and pediatric adaptability for our device. So this slide shows how our first prototype smartphone integrated laryngoscope works. Basically, an endoscopic camera is mounted with the laryngoscope blade, which is directly connected to a smartphone via USB. So an app will be, the footage will be shown in an app in the mobile phone. So this is the final prototype of our first design. This is truly a novel design. Currently, no commercial laryngoscope offers smartphone integration in such a low cost and compact form. While our mobile-based version leverages the existing smartphones, this design offers a fully standalone solution. We have used a display instead of the mobile phone. This display is powered by an internal battery, eliminating the need for any external device or any app. So here is the image of our second prototype. This is lightweight, portable, and instantly ready to use. You can just power it on and begin. To increase the usability across all age groups, we have designed different blade sizes from neonates to adults. This makes our device suitable for use in pediatrics also. To validate our design, we have performed a trial in intubation mannequin. Particularly, this type of intubation mannequin is used to train the doctors for intubation and video laryngoscopy. Here you can see a clinician using our prototype for intubation. So this is a real footage captured by our endoscopic camera during the intubation trial. Can you play it? Sorry. So here you can see the clearly all the airway structures are visualized. So here are all the clear visual details, which are very crucial for the intubation process.
The donut chart breaks down the cost of our prototype around $40 for the mobile phone based approach and $80 for the inbuilt display module type method. The bar chart shows the cost of commercially available video laryngoscope, which cost around $1,100 to $2,500. Our prototype is within 10% of that cost. We produced our design maintaining the regulatory requirement of Bangladesh like DGDA and ISO standard for safety, performance, and biocompatibility. Our prototype have several limitations, including better camera resolution and visualization, and also we have restricted sterilization method for the material we have used. In future, we will seek regulatory approval, launch clinical trial, optimize the design from the feedback we got from the doctor, and we'll go to large-scale manufacture to meet the healthcare demand. Let me introduce to our team. We are a team from Biomedical Engineering Department from Bangladesh University of Engineering and Technology. Our clinical supervisor is Dr. Tariqul Hamid, and our advisor is Dr. Muhammad Abdullah Mamun. In conclusion, Scope is a better, Scope is a step forward towards affordable airway management system which can save lives and reduce cost by millions in low and middle income country. Thank you.
Having had to intubate patients, I mean, I wish we could have had something like that, because it's really, I mean, it's difficult to find it and to see what is inside, and you want to then put a tube inside the trachea and give the air that people needs. But the question that I have is, do you have any feedback from the users?
Yes.
Because from my point of view, if you ask me, I haven't used it, okay? But one of the things is that you need, I mean, it looks like having the camera there, it must be, the weight is one thing, because you have only one hand, so it might be heavy, and not very easy to handle, because when you are trying to find where to put the laryngoscope, you have to move it like this. So I wonder if, I mean, what the people had told you, and if you haven't thought about having the camera on the side or something, so you don't make a device that is difficult to handle, and especially thinking about women's hands, okay, not only men hands that are smaller and much more difficult. Unfortunately, several of the things that are made for physicians are made for men's hands, not for women physicians?
So firstly, we have used the material PLA, which is very light. So, so an woman or a man, anybody can do the intubation. Oh yeah, and maybe you are talking about the radius of the handle, which is quite smaller. We have designed to optimize for the gripping also. And about the clinician's feedback, we have, after first and second trial, we have reiterated the design multiple times according to the feedback. We have created a channel for the intubation tube. In the first iteration, we did that.
The doctor advised us to include a channel so that we can pass the intubation tube directly to that channel, so that guides the tube to the larynx. That's what doctor said us. We have improved based on the doctor's feedback.
Hi. Could you tell me if your device is intended to be reusable, and if so, how would you go about sterilizing it? I think I just heard you say you're using it out of PLA, which is not autoclavable.
Yes, we know PLA is not autoclavable because it has low melting temperature. So we have to sterilize it by ETO.
Yeah, we have to sterilize it by ethylene oxide. We have talked with the clinicians. If you use ethylene oxide as a sterilizer, we can reuse it multiple times. So,
doctor have also said us that we can also use hot water if it is in the environment for less time, or if it is in more environment for a greater time, we have to use ETO, ethylene oxide, for sterilization. It is a chemical sterilization.
And I would like to start this presentation asking you a question. Will you get on a plane that has been recorded multiple malfunctions? Well, no worry, I hope you don't. But this wouldn't happen because the aviation industry has a development system of registration failures. And that's why this doesn't happen. But now we'll change this context. This is not a plane, it's a mechanical ventilator that has been reporting multiple malfunctions, and your relative lives depend on it. How would you do to trust on this device? Well, inoperative medical equipment is a big issue, not only in Peru, in all around the world. We have estimated cost that is $300,000 per hour having a medical device in downtime, and the equipment in Latin America, the 30% of this equipment in public hospitals are inoperative. That's why this is a big issue, a white elephant in healthcare, because it costs millions of dollars that are lost in Peru. These are our daily news in our country. The lack of medical devices that are operatively costs not only money, it costs lives. That's why this is important. And this is our testimonials from people in Peru that says that the lack of incident reporting for medical equipment leads to their inoperability. And also, it delays the patient care. These are our collaborators in Peru, private clinics such as Cayetano Heredia Clinic, and public hospitals, neoplastic ones, and Peruvian Association Clinical Engineers.
That's why we created Astro Management, each incident a lesson, more safety and more life saves. Astro was developing following different requirements. One of them is the capability to be a tool that has that is easy to learn and easy to implement, has to be or has to overcome the technological barriers such as the low spec mobile phones or laptops or PCs that are currently used on the facilities, also to promote the adherence and the acceptance of medical staff, also to take advantage, but not replacing the current managing system that are using in the facilities, and also to promote the traceability through real-time monitoring of medical devices. This is how our solution works. We are based on a Telegram chatbot that has many of the capabilities. In this case, the first one and the main one is the report of an incident. We support a lot on the nurses specifically because they have the problem most of the times. Also, we can track the location that is a problem too in public hospitals in Peru of different medical devices, and also to manage and organize the engineering tasks. Also, this is automatically reported to the engineering heads, the nursing heads, and how can we access to this tool? Just scanning a QR, and how can we know all the information related to medical device? We have the ID related to this, so we can read just 30 seconds, and all this information is stored in a Google Drive. This is how the implementation found. We first prioritize the areas where we are going to work, then we train the staff. It almost takes 5 minutes. Then we put all this together and start running the software. Okay, this is the proofs, the training, the use of QR codes, the synchronization tests. And how can we measure this? Through key performance indicators like equipment downtime, uptime, mean time to repair, and mean time between failures to our available data to take decisions. And in comparison with market, we have fast registration with chatbots and low-cost alternative.
One of the part of the stakeholders are the entities such as regulators, clinical hospitals, and medical device suppliers. And the other hand, we have users, biomedical engineering, facility managers, and healthcare professionals. They both share the same goal, which is improving the patient safety. And the expected result, we expect to achieve the 30% reduction of maintenance costs and the 40% reduction in downtime. And well, part of our success are these other testimonials, which is they have a positive impact of our solution in clinical operations. And well, we also last year met the representatives from the oncology department of the Ministry of Health of Peru. And one of the limitations that we talked about was the cybersecurity. And that was important because ensuring data is important, an essential part of our project. And that's why in our future plans, we aim to establish new partnerships with new institutions in Peru and international to help us overcome these limitations and to scale our solution. This is Astra Management, and we are committed with patient safety, and thank you.
Well, I assume that a user of the system who's going to enter an incident report has to somehow have a login or something. Maybe that's not the case? That's not the case. It's not? It's not the case. Okay, so if you have the QR code on the device, you can enter an incident report?
Yeah, we can access the tool just scanning, for example, this QR here. So the user is took to the chatbot, so they can start just typing, and all the information related with medical device, like serial number, the date of maintenance, the problem as itself, the story of maintenance also are just related with the main inventory of the facility, and also we access to the related ID. So we have the main inventory, we attach an ID to each medical device, so the user can just type that number, and all the information that are like 7 columns or our table or of our database is automatically, how can I say, reported. Yeah.
Thank you.
I'm going to come around this way.
Yeah, thank you for the presentation. I was just wondering, how do you take care of malicious inputs? Somebody who just wants to spoil the name of a good equipment and just key in some wrong information.
I don't understand malicious.
Malicious.
Okay, yeah. Well, that's why we are starting to put an eye on cybersecurity system that we could develop in order to don't have these problems by using these QRs, because we are using Telegram and Google Drive that are open source,
alternatives.
We also support with the informatic engineers on the facility, so our implementation is almost at the same level of this. So we can put this on a PC, protected also with by the. We put the software on a PC, protected by the staff, and that ensures the safety in this case at this level. Obviously, we have to improve this. For example, we were discussing this problem with DGMIT, which is the in comparison with here will be the FDA in some way of Peru. So we have how can I say? We have the option to implement this on Cajamarca using HL7 as a protocol to ensure cybersecurity.
I think we have time for one more.
So, thank you for the presentation. What sorts of do you have any examples of live chat? I mean, do you have an example of how this interaction goes, or?
Yeah, we have a video. This is a staff training that we do at Clínica Médica Cayetano Heredia, and this is how we were testing our chatbot. In the image that are up, we set the QR identifications, QRs for multi-medical equipment, and then tell the nurses and clinical engineers how this is working, so they could has this system to report the incidents in a better way and collect this data in order to make a traceability for the device and how it is functioning.
Hello, everyone. We are the Queen's Biomedical Innovation Team from Ontario, Canada, and we are presenting our solution for a customizable 3D printed above elbow prosthetic for refugees of the civil war in Myanmar. In Myanmar, landmines remain a silent threat. In 2023, over 1,000 casualties were reported, but without formal surveillance, this number could be even higher. For those who survive, it's not just about mobility, it's about dignity and the ability to provide for your family. Over the past 2 years, an estimated 1.5 million Myanmar nationals have crossed the border from Myanmar into Thailand seeking safety and medical aid. With a clear need for accessible healthcare along the border of Myanmar and Thailand, BCMF, or the Burma Children's Medical Fund, was created. BCMF provides support for refugees regardless of their immigration status. The clinic provides medical treatments and support services, including 3D printed prosthetics for refugees who have suffered from limb loss. Their 3D print team consists of 7 3D printers and 5 staff. With the limited technical expertise of the staff, they rely very heavily on open source CAD designs. And there's many models available to the clinic for different types of limb loss, but no model exists for an above elbow amputation. There are over a dozen patients that are currently waiting for this type of prosthetic, resulting in a major gap between available prosthetic solutions and patient needs.
The Laboratory for Percutaneous Surgery at Queen's University approached us, Qubit, to help support BCMF in bridging this gap. Having spent 3 months volunteering at BCMF last summer, I've gained firsthand insight into patient-specific needs and environmental aspects, enabling us to work closely and effectively with BCMF staff. This has helped me significantly as the project manager for this project, leading engineers at Queen's University to bridge this gap further. We have designed an above elbow prosthetic using both our new designs and open source designs found. This is printed in BCMF and tailored to patient-specific needs. The design must enable fully body-powered movement, and it must be only made with materials found in Thailand. It must allow for the patients to return back to their normal life or help them do so. The forearm and gripper hand were taken from a website and downloaded from Thingiverse, which houses these open source designs. To make this below elbow prosthetic that we found into an above elbow prosthetic to bridge the gap, we added a elbow and shoulder addition. So what we did was we uploaded images of a human shoulder into Fusion 360 and modeled this CAD design around it. And we have to edit the open sourced models that we have found to fit the wire harness system so that it reduces snagging. Combining our shoulder with the open source design has resulted in this above elbow prosthetic. We modify this prosthetic to fit the patient's unique measurements by using OpenSCAD, which is a software where you can input models and you can create, which we created, a user interface where you could toggle the size, length, and circumference of the arm to fit patient-specific measurements, and you can download this and 3D print them either here or in Thailand. The harness is very simple. It's only made with nylon straps and a wire, and they're sewn together and attached to the arm, and as I said before, it's rooted internally to reduce snagging. The harness design utilizes abduction, adduction, and shrugging motions of the shoulder to enable this movement. The final prototype combines the PLA printed harness, arm and the harness to complete this prosthetic. We added everything to a GitHub repository as we update these iterations. Making this prosthetic is an iterative process with constant communication between us and BCMF. When we are happy with an iteration, we send our files to BCMF and they print them over there and they test them with the patients, with the amputated patients, and they test for both comfort and ability to carry out daily tasks like riding a bike.
So the device is very low cost right now. We've estimated material cost to be around $8 to $13. We've talked to BCMF though, and they've estimated that the total cost per patient will probably come to around $30. We've had a lot of clear successes so far in our project. The first is that we've made it fully with materials that are already available at the clinic, so not going to need to go out of their way to purchase any. We've also made it fully body powered, so it works very well only with movements and no electrical components, and we have made it open source and simple so it's easy to recreate. There are some key limitations so far. The first just being that it is PLA filament, so it might wear down over time. However, the prosthetics are currently made with PLA. They've had no problems so far. They usually can last up to years, even in their harsh climates. Our other main issue is range of motion. We have the gripper motion working, but the elbow motion we are still working on. So that is one of our first steps, is just working on that elbow movement. We're also finishing up just refining the final design and making sure that it's up on GitHub and working properly. We have a student going to Thailand over this summer to keep working on this and also to finalize the elbow motion. That way she can help them firsthand get the workflow going on in BCMF in Thailand. Finally, we hope in the next coming years to make this more of a global effort and implement it elsewhere. There are some conversations right now between the lab and some project managers in Mexico. So in conclusion, we're hoping that this collaboration helps highlight how partnerships between NGOs and university can help bridge healthcare gaps. Ultimately, we hope to make low-cost and high-quality prosthetics available worldwide to help empower individuals with limb differences. Thank you.
When you started with a Thingiverse design, you actually started with a Thingiverse arm design and improved upon it, and is that true?
Yeah, so they have a lot of Thingiverse designs that they use in Thailand, but there were other problems that came up with it. For example, with the below elbow prosthetic, the elbow would slip out and needed to be fit back in. So one of our collaborators in our group, she made like an elbow covering. And so since we did see like another additional gap of no above elbow prosthetics, we further edited that open source model.
Thank you. And your harness looks relatively simple, but I know how complicated sewing some things can be. Did you place the pattern for the harness in the repo as well?
Yeah, so we've been making a diagram-based manual for them. We've already sent it to them like 3-4 months ago, and it's pretty easy to follow. And we also made a video pretty recently for them so that they could also follow the video. And our partner that is going to Thailand this summer to implement it, she is in that video both to maintain trust and also so that they can see that they can ask her questions at all times.
That's fantastic. I'd really like to see it in the repo.
We are from Bangladesh, and Bangladesh has a lot of refugees from Myanmar, right? So that's Rohingya community. I think you can get in contact with them and get some feedback from them as well about their needs. And another question I had was, you mentioned PLA filament, right? So to my knowledge, PLA is moisture and temperature, it's kind of susceptible to it. So I'm going to ask if you had considered any other type of filaments.
Yeah, so it depends on the prosthetic that they're creating. For example, if they're creating a finger prosthetic that we were working on last summer with them, we were trying to do it with TPU, but for the arm prosthetic, PLA has been tested just in the environment and in the city that they are in, and it's proved to be the best one. And yeah, when I was there last summer, we had a lot of collaborations, both like on the other side of Myanmar and on the other side of Thailand near Cambodia, doing same like lower limb, upper limb loss prosthetics.
Globally, medical errors are the third leading cause of death after heart disease and cancer. And this is in part due to the fact that doctors have to perform high-risk medical procedures under emergent and time-limited conditions. This is even more prevalent in lower resourced areas and communities that do not have as many medical resources or personnel, making them more susceptible to unsafe care. In specific, the mortality burden of medical emergencies is 4 to 5 times higher in these low-income countries in comparison to high-income countries, making this a leading global health need that is unmet.
One of the most common yet high-risk medical procedures is ultrasound-guided central venous catheterization, also known as CVC, into the internal jugular vein. CVC is frequently necessary in emergency settings when patients are in need of high volumes of essential fluids. The procedure is initiated with a needle insertion into the desired vein with visualization assistance from the ultrasound screen. Due to a high level of training required for consistent, accurate needle insertion, CVC can lead to life-threatening complications that typically arise from puncturing the carotid artery, a major blood supplier that runs parallel to the jugular vein. Complications are drastically amplified in low-resource communities, making it even more difficult for clinicians to accommodate for patient-specific challenges.
And we aim to implement our device within such low-income communities where quality medical resources are most vital. And our device's low cost, compatibility, as well as mass producibility allows us to do so. Moreover, our device's intuitive use, as well as simplification of the CVC procedure, allows a broader range of medical personnel to be able to use our device, ranging from doctors to also nurses and residents, but also importantly, first responders and military personnel.
To tackle this problem and address physician needs, we came up with 4 important design rationale and criteria. So first off, we want the design to be attachable to ultrasound models so that we can corroborate the needle movement with ultrasound visuals. Second of all, we want the design to be easy to use so that we can bridge skill gaps and reduce user error. Third of all, we want the device to produce accurate needle placements so that we can reduce complications associated with this process. And finally, we want the device to be able to speed up the process because patient lives are often on the line here. So our device implements the attachability component with a compliant clamp using concentric rings that allows it to wrap around many ultrasound model sizes. To implement ease of use and accuracy components, we have a swiveling needle channel that rotates along a 90-degree protractor, and this allows the physician to fix the needle trajectory to the correct angle. And finally, speed is automatically addressed by a combination of the above components. Because if the physician can produce accurate results with relative ease, then certainly they can produce it relatively quick.
Putting this all together, our device serves as an assistance mechanism to doctors and other clinicians who are performing this procedure. The way that it works is that first, the clinician will use the probe to find the vein, as shown on the image to the left.
On the ultrasound screen, the clinician is able to figure out what the depth of the vein is and then map that onto our device as shown on the image to the right. Once the clinician is able to find the correct angle and depth, they can then perform the rest of the procedure without further complications, including the needle, wire, and catheter insertion.
To ensure the validity of our design, we tested how our device would improve the CVC procedure through using a phantom gel model that mimics the neck anatomy. And we found that needle insertion had a horizontal variance of 1.4 millimeters and a vertical variance of 1.5 millimeters from the center point of the jugular vein. And this is well within the acceptable bounds, given that the average diameter of the jugular vein is 10 millimeters. Moreover, time was an essential constraint given our applications within emergency settings, and we found that all our procedures took under 2 minutes, which is far below the current standard of practice, which could take up to 15 minutes. And currently we are collaborating with trauma surgeons and residents from the Duke Hospital in order to test our device on pig cadavers as well as CVC line placement mannequins to obtain qualitative feedback on our ease of use.
From our testing, we have determined 3 key successes, so accuracy, speed, and attachability. We have achieved consistent successful results in accuracy, retaining speed as well, as our tested trials are under 2 minutes. Our clamp is also compatible with different ultrasound probe sizes, and we're also working on 2 main limitations that we found through our testing, which are that our device may not work with every needle because we have to account for needles that are too short or too long for our device, as well as nonlinear scaling of angle depth mappings.
Building on all the progress we've made this past year, we're continuing to gain feedback and to refine our device so that it better fits market and user needs to better go to our goal of public disbursement.
We're currently conducting a systematic review by looking at current evidence and research on complications and complication rates associated with ultrasound-guided needle insertion in order to improve our device to meet those needs.
We're also working to obtain the necessary funding and resources to begin releasing our device on a global access, such as through injection molding, which would drastically reduce the cost of our device.
And finally, we aim to collaborate with a broad range of medical professionals so that we can branch out the usage of a device to different anatomical features and attain more feedback.
Thank you so much for listening. We'd love to answer any questions.
I noticed you've chosen to align your device perpendicular to the probe as opposed to parallel, and I'm wondering, was that a conscious choice? It's easier, I mean, because you're only going to see needle entering vein when you're in the field, as opposed to when you're in parallel with it, you can see the entire track.
Great question. So currently in the standard of practice, doctors will use the cross-sectional view of the vein so that they can see the jugular vein and the carotid vein or carotid artery, and that they can also see the needle during this procedure as well. If they use the other longitudinal view, they will not be able to see all this, and it's not usually the standard of practice.
So I think this is an interesting device, but from the point of view of global need, okay? I have done several CVCs. I have never used ultrasound because it's not available. So in most of our hospitals, we don't have that available. So actually, initially, when I was listening to you, I was expecting that maybe there was another way. So we have to almost remember how the anatomy is and try to guess where it is. So I think it's great to have a way of directing once the ultrasound is, but probably and I'm challenging you because we need to go a little bit further. So ultrasounds are not that available, and unfortunately, probably this could work very well in wards in the US and other parts, but may not solve the problem that we have at the global level.
So a big part of the reason why we took on this project was because our client came to us with this issue that happens under emergency conditions, especially in military settings. And so our device does center around an ultrasound, but ultimately what it does, it provides a needle channel for the vein. And this could be used for practicing procedures. It could be used for residents, for nurses, of people. We're trying to level the playing field of the amount of people who can perform this procedure, especially for those who are part of the military or in under-resourced conditions, where we can have some kind of ultrasound, whether it be portable or even if there wasn't an ultrasound, our device is in the future going to be able to accommodate for all different kinds of environments and conditions. So that is a future goal that we have, but for right now, we're focusing on how we can best make our device accommodate a lot of the issues we see in the world, which includes the military and in places that do not have the amount of medical personnel and the expertise levels that we see here in the US.
Not all babies are born ready for breastfeeding, which makes them 13 times more likely to face infant mortality compared to non-breastfed infants. Our client, Dr. Pena, experienced this firsthand. His son, Max, was born with a tongue tie and low muscle tone, which prevented him from breastfeeding properly. The result, after coming home from the hospital, months later, they discovered that he had these issues. And the result was that he was fortunate enough to survive, but other infants don't necessarily get that scenario. In fact, up to 60% of mothers stop breastfeeding earlier than intended. So there's a need to create a solution that targets these downsides. The glove test is a simple and affordable method that is used by lactation consultants to assess the feeding ability of infants. It involves placing a gloved finger in the infant's mouth to assess their sucking reflex. And while it has its benefits of being simple and not requiring equipment, it has many limitations. For example, it is not quantitative, and it's actually incredibly subjective because it's based off the lactation consultant's experience. In addition, it's not accessible because it requires an appointment with the clinician. And on top of that, it doesn't involve any feeding, meaning it can't really tell us how well a baby is breastfeeding. Existing solutions have attempted to address these limitations through a number of designs. Take, for example, the Infant Thrive breast system, which involves using a smart sensor and an app to assess the infant's ability to draw milk from the mother. However, this also has several limitations, and it's still not exactly the best improvement compared to the glove test. For example, it offers limited insight. By offering only milk flow, it can't really give us a comprehensive understanding of breastfeeding. And in addition, at $300, it remains expensive. This leaves a critical gap for an accessible, affordable, and objective system to measure infant breastfeeding ability. Our team endeavored to create a solution that addresses the limitations of these existing solutions. We endeavored to create a solution that is low cost, that provides relevant and objective data to quantify infant breastfeeding ability, while also providing an analytical interface that is highly accessible to parents. Through this engineering design process, we started off with several ideas, and over a period of months, we went down to a single solution. And through that process, we came up with several constraints. One being that it had to be non-invasive, had to be safe, had to be accurate, and had to be precise. And our objectives were that it had to be inclusive of all infants, accessible, performs data analysis, and has an easy-to-use UI.
And so this is our design concept. Our design concept has a pressure sensor which is connected via tubing to our nipple shield. This allows us to gauge the negative intraoral pressure that is at the breastfeeding site and exerted by the baby. This simple and meaningful idea allows us to extract this while preserving and helping us to take care of the mother-infant connection. It allows us to maintain an affordable and accessible way to get this information. And so when we were designing our latest prototype, we wanted to focus on a design that was highly functional and highly affordable. This is our latest prototype design, and at the heart of it is a micro-pressure sensor which is neatly and seamlessly integrated with an Arduino. It's held in an armband that attaches to the mother's shoulder, and through the side protrudes a tubing that connects directly to the sensor and the nipple shield. The nipple shield is on the mother's breast and allows us to extract data during breastfeeding. Data is extremely important to our project, but raw data alone is not going to cut it. And so that's why we built a user interface. This is a look at our user interface when you just start the oral feeding experience. Prompting a 60-second test allows the user interface to gather information like pressure, humidity, temperature, and other vital signs that are crucial to the breastfeeding process. And we tabulate these devices and these metrics in a way that is easy to use, easy to interpret, and allows physicians to find and target the early onset of diseases and inaccuracies in the feeding process. But we wanted this process to be interpretable. And so we built an algorithm that gives a test out of 100 based on that baby's feeding score. How does this algorithm work? This algorithm looks at the highest suction pressure that the baby exerts, the average pressure the baby exerts, the duration of the pressure, and even the stability of the pressure through standard deviation techniques. We also have test metrics and we provide recommendations based on this model. But we know that data is not everything, and mothers need support. And that's why we built AbiCare as part of our device. AbiCare is an AI-powered clinical assistant that helps mothers get the data and the information that they need when they need it most. So whether it be a query about feeding, about latching ability, whether it be a query about the mother's weight gain or the baby's weight loss, AbiCare is there to help, acting as the perfect complement to infant suction and breastfeeding. So there you have it. We built a fully functional UI and an infant suction monitor with real-time pressure sensing. It accounts for the biomechanics of the breastfeeding process, and it also measures the personalized infant suction connection. Moving forward, we really want to work on clinical testing. We want to go into optimization of our battery life and the durability of our device while cutting the cost even further. And so here's a sneak peek at our next steps. In the future, we want to reinvent the nipple shield, making it smarter and sleeker through an inbuilt streamlined tube connection feature. We want to look into new pressure sensing technology and improve the accuracy of our device tenfold. Dylan?
Our next steps are to initiate clinical trials with local healthcare facilities. We want to begin collecting data for machine learning development. We want to pursue necessary medical device certifications and then ultimately plan a pilot implementation in a low resource setting.
Really cool product. One question I had is, how do you objectively determine with the metrics that you're extracting what is good and what is not?
Yeah, that's a really good question. And so the key answer to that is the mathematical models that we did. So we worked with Dr. Barons from UT Health to design a system that allowed us to figure out good feeding and bad feeding. That's the number one problem that mothers wanted tackled. And so through these mathematical models that we developed with Dr. Barons, we were able to find an objective split of data that gave you good feeding and bad feeding. This took hours and hours of fine-tuning, but we were able to find peaks and we were able to find consistencies in the data that allowed us to categorize this feeding. So it was through the help of Dr. Barons and then multiple mathematical iterations that we were able to find that process.
Also to add, Justin, to address what you were saying, like with pressure data, because breastfeeding is kind of like a multifaceted aspect where it involves sucking and swallowing and breathing, pressure data would basically give us the best, most comprehensive understanding of how the baby is breastfeeding. And so by collecting that data, that would give us, I guess, the best understanding of the infant's ability to breastfeed.
One quick clarifying question. On the data you said you collected with the professor to fine-tune your models, sorry, I might have misunderstood. Was that data that you collected through actual clinical testing?
No, that was data that Dr. Barons, our mentor, had collected through her own testing.
Thank you.
All right, hey everybody. My name is Sanjay and my partner is Tatiana. We're both from Rice and the Mohawk University of Business and Applied Science. We're here to present Respira, which is a resource-limited educational simulator for pharyngeal intervention and respiratory airways. Quick So here's my partner and I. We worked on this 2 months in Malawi, where we did needs finding at the Queen Elizabeth Central Hospital, worked on the project at the Mubaz Design Studio, and eventually brought it back to nurses to see what they thought. So let's start off. Every year across the world, 1 million newborns die before they hit the second day of their life. When you stretch that to the next month, especially at Malawi, those statistics become more harrowing. But the stories behind those stats are extremely vast and diverse. But a common diagnostic theme that we see is birth asphyxia. And while a lot of newborns can't breathe because amniotic fluid covers their mouth and nose, and which can be fixed by a simple wipe of the cloth and suction from the outside, a more riskier one happens when feces is surrounding the new infant, or meconium. And when that fluid enters and endangers the upper respiratory cavity, meconium aspiration syndrome is a very real, risky, and dangerous outcome, where many guidelines suggest that nasopharyngeal or oropharyngeal is the best solution forward. It isn't for all babies, but for some of the most critical conditions, it is life-saving. But this procedure is extremely hard because it essentially involves putting a little plastic tube all the way through a neonate's nose or mouth, up into the upper respiratory airways. And you can kind of break down the complexity down to the intricate anatomy, the difficulty of doing the technical procedure of balancing harm versus benefit, and also understanding the clinical judgment of when to and not to do this invasive procedure that is life-saving. Now, to kind of explain why this is a difficult procedure kind of comes down to what we're dealing with. As a neonate, you kind of have to be able to navigate through the upper roof of their nose, nasal cavity, make sure you're avoiding the tongue, but also make sure you're not stimulating the vagus nerve and causing them to possibly go into cardiac shock, or possibly stimulating the trachea and making them start spazzing out or choking on themselves. You also have to make sure you're not going too deep, and you do that by using the baby's outside body proportions to predict their inside. And so what we really wanted was a model that kind of replicates what you see on the left, where you have the anatomy, you can have that practice of actually feeding a plastic through, and you get prepared for the real thing. So your first time shoving a tube down an infant isn't when that infant needs help. So we looked around for a training model that can do just that, and it was honestly not that, it wasn't exactly what we were looking for. So the most popular global health model, which is one that I really like and kind of get inspired by, is the Help Babies Breathe, where it teaches some of the most essential resuscitation skills for the first 5 minutes of life, but it doesn't really cover invasive procedures like nasal or oropharyngeal suctioning. It just has a simple pipe down through the mouth, and honestly, even I can shove a plastic piece down that pipe. It's not something that involves a lot of training. And when we talked to these nurses, the more harrowing story that came was that they had to learn how to suction and do these procedures with toy dolls that they're finding in the local markets. That is nothing like a real neonate. So we decided to turn that tail and produce an actual solution. And what we envisioned was that we want every baby to look like the baby you have in front of us, and there's going to be several steps to get there. The basic step might be bulb syringe suctioning. The next step might be oral or nasopharyngeal suctioning, and possibly, once you get advanced enough into healthcare system, you're able to implement drugs to save neonatal lives. While this is an invasive procedure, I believe it can help push the boundaries of what we aspire for global health solutions to look like. And even though the technology might not be there all across global health settings, this is something that I feel was going to be our focus of making sure there are trained professionals across the country such that it becomes easier to roll out these suctioning devices since we have healthcare professionals that know how to use them. So now, this is the model we envision. A training model that is anatomically accurate, responsive to users, and stimulates real-life scenarios. And being global health, it had to be affordable. So we went to thinking and started designing for the next 2 months. We met a lot of failure. And the problem was that we were kind of doing something new where we couldn't really just copy-paste an old design. So it came through a lot of trial and error, talking to our clinical mentors. But eventually, we got something that was highly accurate to what we believe would be beneficial for suctioning. We had something I'm very proud about and excited to show you guys is a very similar anatomy to an actual neonate, where a lot of the nasal, oral, and deeper airways are actually replicated such that you can practice on what's very similar to a baby. We also have a lot of digital features, such that when you actually go push the tube through, you get a response through lights. They're sensed by these photomicrosensors, and you get to see what it's actually like to suction a baby and get responses to what's good or not. And our hope is that for students, it means that we can actually effectively train them, and it's also accessible to local practices. Like in Queens, they use NG feeding tubes, and these same feeding tubes work on our model. But one of the most important parts of global health is knowing when to cut down on the fluff. And what we realized is that maybe what might be the cheapest and most beneficial model is just a simple 3D print that anyone can download and print on their 3D printer, bring to their nursing or medical schools, and just have something to actually practice the tool on, just see what the inside looks like. To maybe it doesn't report it digitally, but they can open it up and see how far do they end up suctioning. And we have a lot of results from the nurses and doctors. We found it to be a really great device. I'm really excited about the way it goes forward, especially with improving training as a whole. Thank you.
How have you quantified the feedback? How are you capturing that? And do you have any numbers associated with that?
Wait, so the problem with quantifying feedback is that real quantification comes from like usability studies with real people, and for that we need IRB approval. So that is definitely a future direction we want to go through, but this isn't the type of device that we can kind of box into a checklist of, oh, we did this study to see like how well it suctions, or we did this study to see like how effective it is. It's more of, it's a very qualitative approach, because that's kind of how teaching is, to be honest. Like it's a very, you figure out what works by seeing how students are learning and stuff like that.
All right, what's one of the most critical insights you got from the iterations?
Sorry, oh, okay, sorry. Critical insights from the iterations.
I think I heard the word failures along the way, and of course they're not true failures. We, learn, but so.
So I guess on, I'll try to say on a personal and a technical level. So I think on a personal level, it's kind of like it just teaches you, to overcome failure and to see where you're going wrong and recognize like the ideas you treasured at first are not as good as you thought they are. But I think on a technical level, think about it, we realized that certain features like the buttons we had might have been too complex, because there's a certain like conceptual model that a lot of users have about like what interacting with a device looks like, and it's really important you're always thinking about them throughout the process. But another one is there's a lot of I say like delays that can happen, especially in like global health research, and it's important to kind of recognize that and also kind of like plan for that, such that you aren't getting too behind and that you know how to catch up. Yeah.
So I have two short questions. Number one, are you planning to sell this, or are you gonna leave like an open source the design so everybody can use it? And the second is, what do you mean by requires IRB study? I missed that part.
All right, so for the first question, it's kind of two parts. For the device that has a lot of technology in it with the sensors, the lights, and the buttons, I think we should sell that so we have a central manufacturing place. We don't have to sell it for a profit. We can just produce in one place and sell it. But then for the very simple device, I think anyone can honestly 3D print this. This can be an open source design. You just have to download the STL file. You just find a nearby place to 3D print it, and you bring it to your school, and then anyone can use it. And I'm really hopeful for that free type of design of open source design. But then for the IRB study, if we really want to figure out if someone truly considers our like device easy to use, I think the best metric would be through a usability study. So that would be like with real people as like participants, and making sure that, because it's human research, that IRB is considered.
Hello, we are the surgical instrument disinfector team from Engineering World Health at UC San Diego. We are interested in discussing the issue of surgical site infections. Currently, they are the third most common healthcare-associated infection, with making up about 21% of all infections. In high-income countries, post-surgical infections can range between 0.5% and 3% of all surgeries. Comparatively, in low and middle income countries, this rate can be over 15%. One of the reasons we are interested in looking into this is the disparity between sanitization methods of surgical instruments between these two areas. The gold standard for high-income areas is the autoclave, which is obviously high energy, high pressure, very expensive equipment. that many low-income areas cannot utilize. So we are interested in developing a model that can disinfect surgical instruments and reduce pathogens that can lead to surgical site infections.
So there were several constraints that we had to keep in mind. So we wanted to make our device low cost and low energy, which means that our materials must be easily available so we can use them for both prototyping and deployment. And also we wanted to make sure that we use low energy. And as we know, we use autoclaves in general to maintain high pressure and high temperature. But in order for places with energy constraints, that energy consistently changes, we know that traditional sterilization methods do not work. Therefore, battery and solar powered device for us was important. Also, we had to keep several criteria in mind. So we wanted to keep like sterility can be verified. So different biological, mechanical, and chemical like methods had to be used. And also we had to make sure for minimal upkeep. So we have to make sure that our device does not require specific instructions to go through and easily usable. And also the material can be held for like a year or longer to be mindful of material usage.
So given this criteria and our problem statement, we came up with this simple design that aims towards full automation. And it's basically composed of two main components. The first one being in the first stage where it's an ultrasonic bath. And the surgical tools are placed on a tray, go through the ultrasonic bath, and then are lifted out of the bath through a pulley system, which is powered by an Arduino. And then it's allowed to dry during the intermediate step. And then in stage 2 is where our UV component comes in. And that's on a timer system with the Arduino as well. And the reason we do a 2-component sort of system is because it optimizes material use, which is essential in resource-limited settings. A little bit of the specifics. For our ultrasonic cleansing, we chose hydrogen peroxide as our solution due to its high affinity properties, as well as it's really easy to gain access to it. The cavitation bubbles caused by the transducer targets debris and other contaminants, which prepares our tools for the next step, which is the UV light. The UVC lamp we use to damage bacterial DNA, and it does this through causing thymine dimers, and we kind of optimize the access points of the UV rays through having aluminum sheets in like the inner parts of our device.
As we've started prototyping, we've had some successes. We have designed the Arduino circuit to deliver power to one transducer, and we have started the prototyping process with the bucket and one transducer. And as we implement the first one, we plan to scale up to 4. We have also developed a thorough testing plan. We're planning to look at 3 levels of instrument capacity, 3 different solvent concentrations, and 3 lengths of cleansing time. However, we've also encountered limitations to our project. For example, the gold standard in sterility verification, which we would like to run before and after using our device, is qPCR. However, qPCR testing is prohibitively expensive both for us and a low resource setting. Our alternative for prototyping is to swab the instruments before and after cleaning onto agar plates and monitor the bacterial growth over time. Another limitation we've encountered is the power supply for our device. We have tested from 5 to 18 volts of power, but have had issues with transducer operation. To fix this, we're looking into higher voltages and using 100-watt drivers. Some of the future directions we would like to take are to make a screen readout to show progress through the disinfection cycle, to make parameters such as disinfection time through each portion tunable by the user, and to further improve our modular design to make more compatible disinfection modules, such as dry heat disinfection. We'd also like to work with electrical engineering mentors to address our electrical issues, and surgeons and technicians to better understand their disinfection needs. Thank you so much for your time.
I believe autoclaving is an extremely important subject in a lot of places, but I don't see that you've shown any evidence that pre-cleaning with your device will improve the safety of autoclaving. Or is it the case that you're proposing this as a substitute for autoclaving?
Yes, so our device is meant in settings where autoclaves aren't working. So for some reason, if like, for example, if the power cuts halfway through the cycle and it stops halfway through, the instruments aren't fully sterilized. So our device is more meant as a intermediary step. So as soon as some basic items are wiped off, the instruments are put into this device, run through the cleaning cycle, and then any further manual sterilization that is needed will be taken afterwards.
So have you tested the how well this work as a sterilizing procedure compared to the gold standard, which is autoclave, based on pressure, heat, and steam?
Yeah, so we just started our research process in November and started prototyping last month. So we are definitely still in the design phase of building something to then, like as Shabika was telling us about our design or our testing plan for once we do have a fully functional prototype. So we have not started any testing yet, but do plan to.
But in your design, have you taken into consideration the fact that your UV irradiation step is not going to get into the crevices or instrument that, that's not just the surface, the flat surface. Have you considered that? Because, you can test, but if you're not having a direct lines of irradiations, your UV is not doing anything, in instruments, and surgical instruments are not just flat surfaces.
No, we understand that. One of the ways that we were trying to optimize the UV that was experienced by all surfaces was having the aluminum lining in the in our container, and also we were attempting to deploy a retractable aluminum part underneath our instruments as well, so that it could be on all sides of our instruments and not just like the top and the two sides. That was definitely something we have considered throughout our design process as one of our limitations.
Imagine you were born across the street at the Texas Medical Center. You are essentially guaranteed to receive a hearing test. Now imagine you were born today in southern Malawi, where our partners work. There are no hearing screenings available. Globally, huge disparities in access to newborn hearing screening exist. For example, less than 1% of the 46 million babies born in Africa each year receive a hearing test, compared to 98% in the United States. Combined, the data is clear. 99% of African newborns will not have access to a hearing test. The consequences of this enormous disparity are heartbreaking, as children with severe undetected hearing loss may struggle to progress beyond a 3rd or 4th grade level academically without any intervention. To prevent these consequences, we must screen babies early. A gold standard in newborn hearing screening in the United States is the Automated Auditory Brainstem Response Test. Here's how it works. First, a speaker emits a sound input to the newborn's ear. This creates an electrical response across the brainstem, which is acquired by electrodes placed on the newborn's head. Thousands of these signals are collected at varying noise levels, and they undergo statistical analysis. This enables clinicians to assess the hearing ability. However, the average cost of these devices ranges between $6,000 and $10,000, making them completely inaccessible to low resource settings. Our mission is to expand newborn hearing screening to low and middle income countries by designing an accessible AABR hearing screening device. Our passion is to ensure that every baby everywhere has access to this critical health technology so that they too can thrive.
Our device was built from the ground up with the following design rationale: affordable upfront cost, affordable lifetime cost and repair, and designed for low resource settings. Here's how our device works. First, we turn our device on, and our ambient sound sensing system assesses the level of ambient noise in the environment. If the level of noise is minimal, we press the Start Test button. A speaker then plays a 70 decibel series of clicks. Electrodes are used to acquire the brain waves from our patient. Our device then outputs a clinical result via our display LEDs. Now looking inside our device, our power management system uses lithium-ion batteries that can be recharged using a USB-C phone charger. To ensure data quality, we use a microphone to assess ambient sounds. A speaker is used to produce our 70 decibel click, and a series of analog filters are used to amplify and condition our signal, which is then sent to our Arduino. Finally, our Arduino performs statistical analysis and outputs our result via its two LEDs. Here, a green corresponds to a passing result with sufficient hearing, while yellow flags the patient for referral to an audiologist.
In order for this technology to reach the newborns who need it, our design rationale is fundamentally driven by its low upfront cost. We've manufactured this device for under $150. This is less than 3% of the price of existing technologies. Secondly, our design ensures affordable lifetime cost. We prioritized repairability by using through-hole components that are easier to replace and less susceptible to physical damage in low-resource settings. To minimize disposables, we implemented a system that uses reusable speaker, electrodes, and batteries. Our life cycle analysis suggests that even after 10,000 newborn screenings are performed, the total lifetime cost will not exceed $600. And lastly, and most importantly, our technology is custom designed for low resource settings. The ambient sound sensing system enables screenings in crowded and noisy environments. The non-contact speaker minimizes sterilization, and the output is interpretable across language barriers.
We're excited about our team's successes. Most analog filters are now functional, with the Bodhi plot demonstrating their correct behavior. Second, our sound sensor can successfully detect ambient noise in the environment, alerting clinicians if data quality may be compromised. This is a major improvement compared to existing technologies. Another success is we developed benchtop testing that can simulate both a brain waveform and residual electrical noise that remains in our filter after signal analysis. We were able to successfully average that data and still clearly get an ABR signal even with noise in our signal. Get that ABR waveform even with noise in our signal. A current limitation of our device is that we only screen at 70 decibels, while current devices screen a broader range. But to lower our costs, we have to remain within the computational abilities of Arduino. Our future work is to refine and filter the amplification symbols and work on a clinical-ready prototype with our partners at Mercy James Pediatric Center in southern Malawi. In conclusion, our device is affordable, incorporating reusable components to expand newborn hearing screening across the world. We are working together to prevent heartbreaking consequences of undetected debilitating hearing loss by ensuring hearing screening is available to every baby everywhere.
So it sounds like you're supporting a right to repair, but it's not obvious that you're making the design available to people that would be necessary for them to repair it. Or do you mean only that the manufacturer can repair it?
We don't mean that only the manufacturer can repair it. We mean that so we're choosing specific components that are more easy to repair. So in a lot of existing devices, you need precision soldering equipment to be able to work with these much smaller components. In our manuals and protocols that we'll be distributing to the purchasers or the customers for our device, we're hoping that with more limited access to repair equipment, they'll be more ready and it'll be easier to repair our device.
To add on that, for repairability, two of our partners in Malawi, so one of them is the Malawi University of Science and Technology. So we've worked with them and they have electrical components there and they have experience with that. And additionally, we work with the Micromech team, which has a makerspace in Malawi. So they actually have it's basically a prototype area, but we've worked on circuits with them before. And so those are other stakeholders that we're working with to support the development of this device.
I have a question about your ambient noise sensing. You mentioned that that will help the users perform the test in high noise environments, but earlier you said it will just be a diagnostic that will tell you whether you can start the test. Is that noise sensing something that will your circuit mitigate any of that ambient noise?
Yeah, so it kind of does both. So first, the clinician will be able to first see if there's too much noise in the environment, and then throughout testing, that ambient noise sensor is still working, and if it does detect that there is a jump in noise or it's above the threshold, then it will emit the signals that it's reading when that kind of larger sound occurs. I hope that answers your question.
The conclusion you can draw from the device is that one may or may not need to see an audiologist. To me, it seems like it's pretty easy to determine if someone has hearing loss. It's just hard to tell how much. So if the device isn't able to tell how much, or can just straight up tell you need to get a hearing device, how much value do you think it's providing, especially to people who, how much value is it providing?
So they don't have any system in Malawi right now for hearing screening. So this is intended to be a preliminary screening, not a diagnostic. But we are targeting babies, specifically newborns, because early intervention is what we're aiming for. So if, say, the child grows up and you start to realize that they're not hearing normally, it's probably too late. The CDC recommends that you provide intervention within the first 6 months. So we can automatically, with this test, at least find out if they have normal hearing abilities or if they need referral to an audiologist so that their parents can be informed so that they can get support that they need to support normal speech and language development, or else the cognitive impairments would be severely debilitating.
I'm Hasani, this is James, and today we're here to present the HemoSave device. Postpartum hemorrhage, or PPH, is the leading cause of maternal death globally. Every year, thousands of women die due to excessive bleeding after childbirth. And in sub-Saharan Africa specifically, PPH is responsible for a staggering 30 to 50% of maternal deaths. One of the biggest reasons is that their current method for detecting excessive blood loss, visual estimation, is highly inaccurate due to blood mixing with other fluids such as amniotic fluid and irrigant. And doctors can often underestimate blood loss by up to 30%. This delay in detection of severe bleeding can mean the difference between life and death for these mothers. And at Kawempe National Referral Hospital in Kampala, Uganda, PPH is the second leading cause of death, confirmed by their chief biomedical engineer. James and I, along with our Ugandan teammates, conducted an intense needs finding process at this hospital, and we firsthand saw how visual estimation falls short for these mothers and doctors. And that's where the HemoSave started. And so, to decrease maternal mortality rates in low-income countries, doctors need a tool that enables them to accurately measure real-time blood loss during C-section deliveries.
So, through end-user interviews and research, we established the following 5 design criteria. First, the device must be very accurate, and we want it to measure blood loss within 5% error, so that blood loss isn't underestimated even in the presence of amniotic fluid. Second, the device should be real-time and give constant updates to the healthcare team throughout the surgery of the exact amount of blood loss. Third, all the materials in the device should be sourced within Kampala, and manufacturing should occur within Uganda so that this can be a sustainable long-term healthcare solution for the area. Fourth, the device should be easy to use and require only one training to become proficient in operation, and the device should also be portable so you can move it from operating room to operating room. Okay, so a device that incorporates all of these design criteria is a significant improvement over the Western standard of gravimetric analysis and the current standard in Uganda in many different ways. First, you're not going to confound the amniotic fluid and blood in your collected fluid. Second, your real-time analysis is going to be a drastic improvement over what's currently done, which is one kind of lump sum of the volume of blood loss which occurs at the end of the surgery. So action can be taken far more quickly. And finally, it's much more labor efficient, especially in a labor-constrained setting. This fits into the current workflow and requires no additional personnel to operate. So here's our solution, the HemoSave device. And the way this works in the OR is basically in two main pathways. The first option healthcare providers have is to aspirate all the fluids in the surgical area that they can into our suction container. When inside, two measurements are going to be taken, a colorimetric measurement and a gravimetric measurement. And so what we're getting from those is the volume of fluid in the container, as well as the percentage of blood that's mixed with the amniotic fluid. When you multiply those together, you get total volume of blood lost. Through end-user feedback, when I went back for a second summer in Uganda, we discovered that they don't just want to use suction in the ORs, also cloths and surgical sponges are a really significant portion of how waste is managed. And so we added these two trays on the side. Prior to the surgery, all the clean cloths and gauze that will be used is loaded into one of the trays. During the surgery, those are used and replaced into the second tray, and a differential measurement of the mass is taken between the two to get the total volume of blood collected in the sponges. And then that total volume is calculated and output to the user on a digital display. But we know they're not going to be looking at that all the time, so we also added an alarm which will sound once 800 mils, which is kind of a physiologically dangerous amount of blood to be losing, is reached.
And after some testing, we're really happy to report that our color sensor can report variations in citrated bovine blood concentrations with less than 5% error, giving us a really good calibration curve that our sensor can then make measurements based off of. Additionally, combining the accuracy of our color sensor with the accuracy of the load cell when measuring various fluid weights, we're able to get 98.13% accuracy of calculated total blood volume when using a blood analog. Additionally, this is all happening in real time, which is one of our most important criteria, with the blood loss measurement being updated every minute. We do recognize that there are some limitations. For example, the weighing trays that weigh the sponges and clots currently assume that all the fluid that's collected in those clots is blood, and that can lead to overestimation and blood loss. Additionally, we haven't been able to test the long-term durability of our device, and we recognize that there are still limited risk managements, and we need fail-safes for edge cases like liquid overflow, clogging, and sensor malfunctions. And so, pathway to implementation, we obviously want to add those risk management mechanisms, update the user display so that the user will have options for certain settings of the device. And I will be traveling to Uganda this summer to meet with our Ugandan teammates and finalize the design with local materials and conduct V&V testing. PPH is an avoidable problem, but it happens to mothers every single day. And our team truly believes that every child deserves to grow up with a mother, no matter where they live. And so our team, both here and in Uganda, is committed to making HemoSave a reality.
Questions about the tray for the gauze and clothes. You said before surgery, you're going to weigh them, and then after surgery, you wait and look for the differential. I presume that includes all the surgical gauzes that they are used, not just the patient's clothes. How do you deal with the question of sterilization?
Yeah, so the plan is for any container that comes into contact with any bodily fluid to be made out of material that is sterilizable. And so that's why we've ensured that the 3 containers that will come into contact with fluid, even clean cloth, dirty cloth, and the fluid container, are all made out of plastic that can be sterilizable, as well as the tubing. But our main concern is that we don't want any of the fluid to come into the pump, as that can't be sterilizable, and that's why we wanted to add those risk mechanisms.
I had exactly the same question.
Yeah. Oh, sorry. So I wonder how this is different from some practices that are already being done at the hospitals or the centers. So what they do is they weight all the things like the blankets and all the things that are going to be used before and after the delivery. And with that, they calculate. I mean, what additional thing are you bringing with the machine at this point?
Yeah, thank you very much. So this technology is mainly applicable to childbirth because of the presence of amniotic fluid. So that normal gravimetric analysis is fantastic when there isn't amniotic fluid involved, but oftentimes in a procedure like this, you've actually got more amniotic fluid than blood. And in that case, if you're just weighing everything, you might come up with a totally wrong number because all of your cloths and gauze will be soaked with amniotic fluid and not just the blood that you actually care about and want to measure. And so that's why using our method, you can get a nice a ratio of blood to amniotic fluid and then apply that to the volume that's been lost.
My concern is on your fixation with local material. I'm just looking at where do you want to use it in the equipment. I'm lost.
When we first started this project, we built our initial prototype in Kampala, Uganda, and so one of our main concerns was that we wanted to be able to source, for example, the sensors, the microcontroller, which in our case is an Arduino, all the materials such as acrylic, to be able to be, and any plastic we use to be able to be found in Uganda. Because one of the biggest problems we saw when we were conducting needs finding in hospitals is that a lot of time when devices are imported from other countries, the second one component breaks, they actually have to just throw out the whole device because they aren't able to import that singular piece. And so the idea with building this out of local materials is like, if for example, the color sensor malfunctions and it needs to be replaced, the biomedical engineer can just go into town in Kampala, buy that color sensor and easily replace it.
To start, this is a bit of a weird question, but can everyone take off their glasses real quick? Okay, so what y'all are seeing right now is what over 2.2 billion people around the world see. Okay, y'all can put the glasses back on. Okay. Visual impairment disproportionately affects people in low-income regions and greatly hinders their upward social mobility. Visually impaired students have a 44% higher chance of dropping out. Moreover, visual impairment issues have costed over $400 billion in productivity and increases risk of anxiety and depression by 5 times. As you all can see, untreated visual impairments can affect a patient's life from school, work, to even their psychology. So you would think to solve this issue, just give them a pair of glasses, right? Well, at first glance, cost appears to be the main barrier as to why everyone around the world remains visually impaired. But the truth is, producing a pair of glasses can cost as low as $5, and there are many organizations around the world that are already distributing glasses to those in need. The real issue comes from the fact that while you can give anyone a pair of glasses, you need their prescription first. That requires a diagnostic test, and the two most commonly used ones today, a digital phoropter and a traditional phoropter, cost from $3,000 to $20,000 and can weigh as heavy as 12 to 25 pounds. Sure, these devices are accurate, but they're expensive, bulky, and impractical for low-income regions. To understand the full picture of this issue, our team was lucky enough to travel to the rural mountains of Vietnam to see the issue firsthand. After navigating difficult terrain, we arrived at a remote community where the families welcomed us warmly, but they shared personal stories of how visual impairment has deeply caused them harm and emotional turmoil. Seeing their stories firsthand has really reaffirmed our mission to bridging this gap in eye care. To see these resilient groups of people face obstacles simply because of their geographic isolation, it really reaffirms our mission that at All Eyes, we believe that in the future, we hope everyone, regardless of where they live, can have access to clear vision. That's why we developed a device that is low cost, easy to use, and portable.
So our design is centered around the lens maker equation you can see over here. This pretty much relates the curvature of a lens using radius to an actual patient's prescription and diopters. So to test our design, we modeled how PDMS, our flexible membrane, bulges or deforms when a fluid is injected behind it. So as you can see in the top left image, when you place PDMS in a circular cutout, it forms a radially symmetric bulge. This closely mimics what you would expect in a spherical lens in a 4-opter. But the clear takeaway from here is that even while bulging or deforming, the optical distortion remains minimal, meaning that we can create adjustable and repeatable lens shapes using a PDMS membrane and fluid control. So our design uses 2 types of lenses to give patients their final prescription. First, a spherical lens, like we talked about earlier, uses a circular cutout. This gives us the first number in a patient's prescription and allows us to correct for nearsightedness and farsightedness. Second, the cylindrical lens, like you see on the bottom, uses a rectangular cutout. This allows for bulging primarily along one axis and allows us to correct for astigmatism, which is unevenness in the patient's cornea. Together, both of these lenses can be adjusted independently and allow us to create accurate and unique prescriptions for each patient without the need for expensive machinery or electricity. So with our 4-opter, we plan to launch in Southeast Asia, specifically in Vietnam, where we've already established contact with multiple volunteer groups that have a vested interest in our product. From there, we'll continue to get feedback from these partners, and we'll continue to optimize our product until we break into South Asia, where over 65% of the population has a need for glasses, but only 7% actually has glasses. From there, we'll continue into Sub-Saharan Africa and eventually into South America. Additionally, with our 4-opter, we simultaneously break into the liquid lens and 4-opter markets, which have a size of 170 and 150 million, respectively. However, the main innovation comes with our lenses, and with that, we can break into the lens market, as there are a multitude of opportunities beyond just the 4-opter.
In total, our product has an estimated production cost of just $55, with an estimated $15 in shipping costs based on Vietnamese rates. In our first year, we're dedicated to targeting underserved communities and reaching them through direct partnerships. We've already established connections with over 100 community clinics, and we're distributing over 100 of these, one to each clinic. But don't just take it from us. Take it from the countless individuals we've interviewed, including one physician who said that our product has the potential to transform lives and restore vision and hope to countless individuals. And no matter how hard the journey may be, we're dedicated to persevering, and we will continue to persevere because we care for eye care.
For the computational model you showed earlier, did you just want to show the bulging, or are you actually using the modeling to refine the designs or anything?
So that was just mainly to prove that when you put fluid inside the PDMS membrane itself, that we can get a consistent curve across it without like a lot of deformities in the actual shape itself, and just to prove the idea that like we could make an actual lens or liquid lens using PDMS as our choice material.
Why isn't like a traveling salesman approach where you just sell like standardized glasses and people just see like what works on the moment and just buy it from them, and they would be like more cheaply manufactured on scale? Compared to, like, why is it so important to get highly customized glasses for low resource settings?
So a lot of the organizations we talk to that have current eye care solutions for these remote areas, they require a prescription for you to actually get the glasses, and they haven't thought about doing like a mass of one prescription. And the other thing is that it's a lot easier for us to get in contact with people who have these kinds of materials like 3D printable, like just 3D printers in general, and like PDMS membranes and that kind of thing. And that's a lot easier for them to manufacture and transport on site than it is for us to find people in these rural areas that have the ability to just mass produce glasses in all this area. Because the highest cost in all of this is that like to destination shipping cost at the end.
How much training does it take for someone to use a device to arrive at the prescriptions? And who are you targeting to perform the diagnostic test?
So our goal for this is that we have no need for a physician or someone highly trained, because another thing is there's a lot of lack of ophthalmologic nurses or even doctors in a lot of these places. So our goal is what we're currently working on is an Arduino program that basically says like, Do you like option A or option B better? And you continue that until you narrow it down right down to the finite range, that basically where the prescription would be. And our goal is to get it right around close to where it's about 0.25 diopters within the actual like accurate number that we would say is 100% correct.
My name is Meg Pardee, and with me are Rosie and Laurel. Just a quick overview of what we will be going over during the presentation.
So what is the problem? Tourniquets are an essential tool used to treat serious traumatic injuries. However, even by trained personnel, they are misapplied in at least 25% of cases. Additionally, prolonged tourniquet use can lead to vascular or neurological damage and limb loss in certain situations. This can be a serious problem for those in rural areas or military settings, as they are most likely wearing a tourniquet for longer than the recommended 2 hours.
Traditional tourniquets are already applied in a wide range of scenarios. However, pressure seeks to improve the efficacy of long-term tourniquet use, specifically in environments where medical attention is scarce, such as rural areas and military scenarios. We've elected these two populations as the greatest risk of long-term tourniquet use-related ischemic damage.
So based on this problem and our identified target audience, we have designed Pressure, a reusable, rechargeable, semi-automatic pneumatic tourniquet that guarantees accurate pressure application and relief for up to 72 hours. Once the user places the device according to printed instructions on the tourniquet, a single push of a button will inflate the tourniquet until blood flow has stopped. Then, 1 hour after application, the device will automatically begin 3-minute cycles of partial reperfusion, resetting to a 1-hour inflation after 5 cycles. By resuming the flow of blood at prescribed intervals, Pressure prevents extreme acidification of the blood and subsequently ischemic damage to remote organs and the injured limb. This significantly increases the safe tourniquet wear time.
We have been continuously evaluating our device based off several key criteria in order to make sure that it stays in line with the core goals that we established at the beginning of the year. Our top 4 of these criteria are completely stopping the bleeding in under a minute, making sure it does not slip off prematurely, making sure it periodically reperfuses the limb, and at 4th, making sure that it fits in the pocket of an EMT or military personnel. We've talked to several key stakeholders, and 2 key points that we took away from them was that the tourniquet has to be applied extremely quickly, specifically within under 10 seconds, if not under a minute. And as well, it has to go beyond the golden hour or sustain life for 72 hours and be long-term sustainability. So is temporary reperfusion really the answer, and is it the solution to our problem? In short, yes. In most studies done in both animal and human models, it has been suggested that tourniquets should not be worn for longer than a maximum of 2 hours. So if a longer duration is necessary, it is recommended that the tourniquet is periodically released in order to reduce the risk of ischemia-related complications. It is important to note that there's not many studies done with tourniquets in emergency situations, and so our team wants to perform further field studies in order to further support.
So why is Pressure the next stage in tourniquet technology? Well, like we've mentioned before, it is, of course, able to stop the blood flow as any tourniquet is able to do, and is also intended for use in emergency. However, what really sets us apart is that automatic reperfusion technology and ability to guarantee a safe application pressure level every single time, both of those factors going in to prevent ischemic damage.
So, as Laurel mentioned, Pressure really differentiates itself by offering both automatic inflation and reperfusion cycling. Even with this additional functionality, Pressure is only priced between $180 and $200, of lesser or similar cost to other devices that do less. Now let's talk about the device itself. Pressure utilizes novel circuitry and a specialized algorithm designed for its automatic inflation and reperfusion cycling. After mapping and testing the circuit, we have condensed the electronic components into a protoboard that is housed within a 3D printed chassis. The chassis is secured to a pre-existing pneumatic tourniquet, allowing for more adaptable design capable of interfacing with other pneumatic tourniquets already on the market. In our future iterations, we plan to continue sizing down our device to better fit our size constraints, as well as making it waterproof and more durable.
Now, to test our design, we created a model leg. Dermisol surrounding latex tubing mimics real tissue with blood flow. In this photograph, you'll see one of the setups that we used. Later iterations of the testing model will likely include limbs of different types and different sizes, so we can ensure that pressure is a one-size-fits-all product. Now, in the coming months, or rather at the end of this semester, we plan on solidifying the pressurization and timing mechanism and condensing our electronic components into a printed circuit board by the end of May. In the following summer, we are excited to bring pressure into the real world. After obtaining a provisional patent and IRB approval, we plan on partnering with trauma centers and ER physicians to conduct field tests and create a marketable product. For our consumers in rural areas, we will be looking into government subsidies to ensure that pressure reaches the people who need it.
Your two target markets, which is rural and military, I see how this device could be distributed in military settings. A medic would have it. How would you distribute this in rural settings that don't have close enough access to?
So what we're thinking is that it would be distributed to the EMTs that will be on the ambulance. So maybe every ambulance will have one of our device, and we have designed them so that the box can be detached from the tourniquet. Both pieces can be sterilized. So our initial cost would be upfront, the $180, $200, and then that device can kind of be passed around in case there aren't enough resources to purchase a lot of them.
It's like, why would an EMT need a device that would open and close in 2 hours if they're only going to be in transport for maybe like 30 minutes at most? They're just going to transfer to the hospital, and the hospital can deal with that issue. So
Yeah, so the average time of 34 minutes in a rural setting is kind of a lower estimation. They can get up to 2-hour transport time. So it can be used in these settings. Obviously, an average means 50% are going to be over this time. There will definitely be a market rather than marketing this towards people in urban areas.
Hi everyone, we're really excited to talk to you about our product, Althea. Unfortunately, globally, 84% of adults experience lower back pain at some point in their lives. That's a pretty broad category, so let's break it down. We care about 3 main characteristics. Axial, which is the most prevalent, and it's where pain is centered around the spine. Chronic, where the pain persists for 12 or more weeks. And non-specific, so there's no singular underlying cause behind the pain, like a tumor or a fracture. Rather, it's a combination of multiple underlying factors, like microstresses, etc. 2 obvious problem outcomes are increased pain and functional disability, but that leads to a bunch of other things, including reduced quality of life, where individuals actually suffer twice the chance of depression. When it comes to work loss, 6 to 10% of workers with lower back pain leave their roles. And in terms of an economic burden, back pain costs 1 to 2% of the gross national product in Western countries. That brings us to our solution, Althea. Althea is a therapeutic back brace that's wirelessly integrated with the phone app. Our user would wear it for around 20 minutes, 2 to 3 times per week, and within 3 to 12 weeks, per clinical literature, they should be pain-free. How does this work? Utilizing a technology called LIPUS. LIPUS, or low-intensity pulse ultrasound, is a novel therapeutic tool being used for a wide variety of medical applications. Now, that's a pretty big phrase, so let's break down what that means. By low intensity, we're targeting a max intensity of 100 milliwatts per centimeter squared. That, combined with being pulsed at 1 kilohertz, helps remove effective heat generation. And then by ultrasound, we mean any frequency over 20,000 hertz. Really importantly, one literature review examined 6 clinical trials for over 700 patients and examining the efficacy of ultrasound therapy in treating chronic non-specific lower back pain. And importantly, it found a significant pain reduction, validating our use of technology in our device.
So when designing Althea, we focus on 3 key design areas: performance, usability, and accessibility. In terms of performance, this is the parameters that are cited in clinical literature as being effective in lowering and reducing chronic non-specific lower back pain. Therefore, we designed Althea to meet these requirements. In terms of usability, we wanted our product to be non-restrictive. Therefore, we've designed it to be wireless with a 3-hour rechargeable battery life and a weight of less than 3 kilograms. We also wanted our product to be compatible with a large amount of patients, so therefore we've targeted the 5th to the 95th percentile of waist circumference, and that is between 71 and 126 centimeters. In terms of accessibility, we wanted our product to cost less than 2 physical therapy sessions and take less than 15 minutes to set up and learn. And this is less than half of what the American National Standards Institute recommends for medical devices. Now, let's look at a couple of comparisons to current approaches for chronic non-specific lower back pain. While there is LIPUS devices on the market, they are cost prohibitive, they are large, bulky, and they require guidance for use. Physical therapy brings some similar drawbacks. Exercise improves on the cost factor, but the other drawbacks remain the same. Medication has many notorious side effects. And our solution is able to tackle this issue with none of the drawbacks.
All right, and here is our final product. So on the inner side of the brace, we see that we have our transducers that emit the lipase waveform to the user's back, and on the outside, we have a covered box containing our PCB circuitry. The first step for the user will be to complete the pain diagnostic questionnaire on the phone app, which gets fed into the algorithm that determines the treatment schedule for the user. The user will wear the brace for the duration of the therapy session and retake the questionnaire every week to adapt and update the treatment plan. We designed our circuitry with the intention of meeting the clinical lipase parameters and optimized it so we could deliver the waveform more efficiently. We then transferred to a PCB so that we can minimize the form factor. Mechanically, we place the transducers according to key physiological landmarks for chronic nonspecific lower back pain. We also designed the brace to be lightweight and have a small form factor, so it's as minimally invasive as possible. On the app, we have a setup page for the user to connect to the device via Bluetooth. The user can also complete the questionnaire, which outputs a personalized treatment plan based on clinically validated pain metrics. On the diagnostics page, the user can keep track of their pain history and observe how their pain levels change over time.
Now that we've made our physical implementation of our device, we've conducted tests to ensure that it meets our need specifications. One of these tests is a power spectrum analysis to identify the fundamental frequency of our signal using a Fourier transform. The fundamental frequency of our signal is 1.0 megahertz, which aligns with clinical literature on lipase. Another test we did was organic material testing to characterize lipase penetration through the human lower back. We used organic materials to simulate human tissues and measure the power transmission through these materials at different depths. We found that the signal can penetrate the human lower back. We also conducted user testing to evaluate the user interface of our mobile app, and users found the app to be quick to set up and easy to use. Now, let's evaluate how Althea meets our need specifications. Althea aligns with clinical lipase literature on the parameters for frequency and max intensity. We meet our aforementioned usability specifications as well as our accessibility specifications. The cost will decrease to $30 to $50 as we scale up for production. As we continue to improve Althea, we'll focus specifically on optimizing to decrease cost and time of manufacturing. We will conduct further thermal validation to robustly validate patient safety, and we'll conduct environmental testing to ensure that you can use Althea anytime, anywhere. As we bring Althea to the market, we must initialize a quality management system according to ISO standards. We'll conduct clinical trials, and we'll apply for FDA 510(k) status. We're excited about the progress that we've made so far, and we're confident that Althea will revolutionize the way that millions treat their nonspecific lower back pain. Thank you.
How does this device differ from the ones that you can find in the market at any retail? That, I mean, the lower price is like $99. So,
sorry, one more time. Can you clarify which devices you're talking about that are priced at $99?
These belts, ultrasound belts for back pain.
As far as we can tell, there aren't any commercially available ultrasonic belts at the scale that we looked for back pain. What we have seen when it comes to applying low-intensity pulse ultrasound signals is the commercial devices are super bulky, get up to $4,000. Maybe you're referring to the 10 stimulation units?
No, I just Googled exactly what I told you.
And
then I found like different types because I have seen it in use.
Yes, totally.
And but I was wondering, I mean, if there is something regarding the technology that is different, because of course, I mean, you have to understand what is the market to see what is the difference that you're going to offer and how, I mean.
Yeah, 100%. My guess is those are likely continuous ultrasound devices. Our main factor is we're low intensity in pulse with certain clinical validated parameters. We're actually working pretty closely with a clinical mentor who runs a lower back pain clinic. He has a bit of electrical engineering background as well, and he's validated that our device isn't, or the ultrasound technology we're using in our device isn't really being used widely globally.
Battery life is the first question. Spend some time on that. Second one being, let's start with battery life first.
As in like how we validate our
Yeah.
calculation for 4 to 5 hours? Yeah, I mean, do you want to take it or I can?
I think we have the calculations at the end.
I don't know if we have the calculation necessarily. You can check. But or go for it. Like how we
And would this be recommended by a doctor, or someone will just order it by themselves from the website? Yeah.
All right, so the way that we validated our power draw and therefore, by extension, our battery life is that we first ran our unit at maximum power under common operating conditions, and then we take the current draw of that, and then therefore we are able to tell what power consumption this device consumes over time, and then we use the capacity of our battery and the discharge rate, and we are able to deduce how long it would take. The issue is that we selected our battery closer to the end of our development because we wanted to look at our total power draw and then look at how long our device has to run per session. And then we'll choose the battery that's small and light enough in order not to exacerbate back pain problems, but able to power our device for the time required for LIPUS. Right now, we have settled on a 1,200 milliamp hour battery, and that's about I think a couple of.
It's not too big.
Yeah, it's not too big. Yeah, it's for drone batteries, and therefore we are able to implement this within our LIPUS device. The calculations we have completed, but we didn't include it in the appendix.
How is it global? Because this is global health technologies.
Totally. I mean, lower back pain is the leading cause of disability, according to, which I think it was the WHO. 84% of adults globally experience lower back pain at some point in their lives. I think around 619 million adults are currently experiencing it. So a very global problem. And then as we scale for manufacturability, our cost should get down to $30 to $50, which is still expensive on the grand scheme of things, but compared to current approaches, is a lot cheaper.